Good morning, everyone. Or rather, I should say good morning, good afternoon, or good evening, depending on where you are in the world. I'd like to welcome everyone to this fourth International NYU Hip Dysplasia Symposium. My name is Pablo Castañeda, and I will be your host today throughout the day. I am extraordinarily excited to have faculty joining us from 6 continents and 16 different time zones. They are all experts in their field, and they've been willing to give up their time today to tell us about their experience. And as we move through, we'll hear about judgment and wisdom as well. We do have a fantastic lineup that starts with a focus on diagnosis, going from the ancient land of the Aztecs with my former partner, Carlos Vidal, in Mexico City, all the way down to the southern tip of South America, where we will hear about a very efficacious national program for screening in the voice of Estefania Birrer. We then will travel all the way up to the Pacific Northwest in Vancouver, where Kishore Malpuri, perhaps the world's most connected hip health expert, will give us his perspective. And end back here in the Northeast with some words of wisdom from Jim Kasser, who I've tasked with distilling a decades-long career into a 7-minute talk. And I think he'll be up to the challenge for it. We'll then switch gears and begin to talk a little bit about treatment, beginning on the West Coast, where Salil Upasani will tell us about the experience in San Diego, returning to the Northeast with Woody Sankar from Philadelphia, and then all the way over to Australia for Oliver Berkey to pick up on some of the nuanced issues. Back to the US, where we have another voice of wisdom in Perry Schenecker. And then we throw it across the Atlantic again and begin to listen to Suzanne Devos Jacobs in the Netherlands and Simon Thomas from Bristol, England. We then get into some of the controversy surrounding hip dysplasia, continuing our program with Alex Arvold in Southampton, and then a couple of British expats, one currently in Zimbabwe, Rick Gardner, and another at Sick Kids in Toronto, Simon Kelly. I know it's quite tough to keep up with this. Trust me, the logistics were tough for me as well. Still, we're going back across the Atlantic, all the way up to Oslo, Norway, where we'll hear from Joachim Horn in Oslo, who is going to tell us about the extraordinary experience in Norway and Professor Terjesen's experience, which is a very long-term follow-up. Then down to France, where Federico Canavese, and round out this fantastic block with the wisdom of Stuart Weinstein, who is a sage amongst orthopedic surgeons. It's an ambitious program. Then we focus on acetabular dysplasia and listen to Debbie Eastwood from Great Ormond Street in London. Moving on to Xuemin Liu, who is going to give us a unique perspective from Beijing, China. Then back here to New York with Ernie Sink, and rounding us out, we'll go back to the West Coast with Stephanie Poon from Stanford. I'd also like to recognize Salil Upasani, who's going to give us a second talk. I asked him to wake up very early for this, and he was up to the challenge. And finally, the icing on this very filling cake we already have is the last session of the day, which I'm genuinely looking forward to, where we'll hear from 2 incredibly experienced surgeons in Teddy Slongo from Bern and Mike Millis from Boston. As you can see, this is truly a global effort, and I am forever indebted to the faculty for giving up the time to prepare the talks and spend the day with me. Hopefully, next year we will be in person again, but I also think that the virtual format has allowed us to have this incredible scope across the world. I would like to give a very special thank you to Ortho Pediatrics, whose incredible generosity has supported this program. Without this, it would have been impossible to do. I'd like to especially thank our team at NYU, Daniel Milbauer, Samantha Phillips, especially Erin Quackenbush and Maria Mercado are truly a dream team. Please put any of your questions into the chat box. We will have time for answering Q&A. And I'd like to make this an authentic symposium in the Greek sense and make it an interchange of ideas and hopefully have some very healthy discussion. I hope nobody's brain explodes at the end of the day, but most of all, I hope that this serves as a launching pad for creativity and future collaboration as well. So I've given myself the task of laying the table and framing this symposium. I have no disclosures that are relevant to any of the talks today. So the first question is, why do I think hip dysplasia is a problem, and why go to the trouble of organizing a meeting like this? Well, if we've learned anything over the last year and a half, it's that nothing spreads quite like fear. Although hip dysplasia is far from a lethal condition, the scope and impact on public health should not be minimized, and I think we would do well to improve. This statement may seem rather aggressive, but it's feasible to consider that 1 in 5 people have hip dysplasia, depending on how you define that condition. I'm a bit of a history buff, and going back through the literature, the first mention that I can find in dedicated orthopedic journals can be attributed to a gentleman by the last name Phelps, who published a paper in 1891, before the advent of radiographs, where he showed this picture of a child with an evident limb length discrepancy. Now you can go further back and read this wonderful study from the UK that looked at the prevalence of dislocation in dysplasia over the past 1,000 years. And essentially what the authors did was they dug up skeletons from medieval London and found a remarkable number of intact pelvises. In fact, they found over 10,000 pelvis. Of these, about 3,300 were preserved well enough to be analyzed. And of these, they found 9 developmental dislocations. They illustrated this with these astonishingly preserved specimens, which are almost 1,000 years old. So what they found was there was 3 developmental dislocations per 1,000 people in medieval times. To take it a step further, they also looked at dysplasia without frank dislocation. And they found it quite frequently in these skeletons that they had dug up. They found these shallow acetabulum with classic signs of rim overload and anterosuperior deficiency, and consequent arthritis, as you can see on these images, which are really quite astounding. What they found was that 1 in 10 fully grown adults had hip dysplasia in a time where the life expectancy was less than half what it is today. Has this changed? Well, in the last 1,000 years, it would appear it hasn't. This prevalence study from Copenhagen used 4 of the most common measures to define radiographic acetabular dysplasia in adult hips. The classic is the center edge angle less than 20 degrees, but they also used a Sharp's angle, the migration percentage, and acetabular depth ratio. And by using these commonly accepted values for each of these to define dysplasia, when they used just a center edge angle of less than 20 degrees as the definitive cutoff, the prevalence of hip dysplasia was 3.4% in this group in Copenhagen. But when they included any of these signs, then the prevalence was 10%, the same as during medieval times. A different cohort study out of Norway used the same measurements and found similar numbers. For the lateral center edge angle, it was 3.3%. But when they included all of the measures to define hip dysplasia, they found that 1 in 5 people, 1 in 5, are walking around on a dysplastic hip. So perhaps we have failed to screen, and maybe this is because screening is defined as the intentional search for a pathologic condition in the absence of signs or symptoms. But one of the problems is that hip dysplasia doesn't become symptomatic or have any signs until it's far too late. We've come quite a long way, and we do have excellent treatments, even surgical ones. And we'll hear from the lead author of this classic study later today, which looked up a cohort 45 years on. with the original cohort that was operated on by Professor Salter in Toronto. Some had bilateral dislocations like this, had the classic treatment of open reduction, capsulorrhaphy, and pelvic osteotomy, and did go on to have pristine-looking hips. But the story wasn't always that rosy, and they were the first to admit it. But more concerning to me isn't that you have isolated poor results. It's when you look at the long-term results using Kaplan-Meier survival curves, using total hip replacement as the endpoint, there is an unfortunate reality in most series. For whatever reason, patients around the age of 30 years begin to decline. And at the age of 40, there is a precipitous drop-off. We will also hear about the 50-year follow-up from Norway in the voice of Joachim Horn later today. And this wonderful paper that they were able to follow up on 50 years of really shows us how we should do a better job of detecting early and treating this with more efficient means. But we'll conclude that the only possibility of having a normal hip after having dysplasia is non-operative treatment before the age of 4 months, which makes the early diagnosis all the more important. So I'll end this introduction here and hand it over to Carlos Vidal, who is going to talk to us about the challenges of establishing effective screening programs, especially in countries like Mexico.
Hey, good morning, everyone. Pablo, thank you very much for the kind invitation to the symposium. It's always a pleasure to be here with you. So let's start with the talk. Let me see here. I have nothing to disclose. And let's start remembering that hip dysplasia, it's by far the most common congenital pathology all around the world. And despite the big efforts for an early diagnosis, it's still very difficult to detect and treat all of them. The main reason is that hip dysplasia can vary widely from stable acetabular dysplasia to a complete dislocation of the hip. And the consensus for a complete universal screening has not been established yet. Late consequences of an undetected hip dysplasia include pain, gait imbalance, early OA, and these heals with premature hip replacement therapy. So, talking about that, incidents can vary widely all around the world, from 1.6 to 28 cases per 1,000 lip births. And it depends on the age of the screening, the ethnic group, but most of all because of the screening method used. Ortho and Barlow maneuvers as a clinical screening are very poor in diagnosing. It can only have a diagnosis value of less than 6%, meaning that more than 90% of all the hips with this screening method will be undetectable. So some image will be needed for screening all the babies. So image screening seems to be the best way to detect hip dysplasia. And the two main methods that have been used are the X-ray and the ultrasound. The X-ray has a positive predictive value of no more than 67%. And the ultrasound, I think it's very good. It has an accuracy of more than 95%, but only when a standardized method is used. And we will talk about later. So general consensus for the ultrasound screening supports its capability on detecting abnormal hip development, but many controversies arise as being as a general or a selective screening method. The main problem is the acceptance of ultrasound as a screening method, and it is based mainly in the inconsistency in the pediatric clinical guidelines. American Academy of Pediatrics established 3 guidelines based on 3 different criteria, and this is why we have a lot of mistakes in doing screening methods. The first one says clinical examination and screening only if doubt. But we have talked that more than 90% of all these screenings will have dysplasia that could not be detected by these criteria. So this is not helpful. Second, clinical examination and screening only if risk factors. But we know in these days that less than 30% of all the babies with hip dysplasia have risk factors. So using this screening method, more than 70% of babies with hip dysplasia will be undetected. And I think the third one, it's the best one. Clinical examination and screening to all babies. If we implement this, this is going to be the way to decrease the incidence of late dysplasia. So why do we fail with clinical examination? Well, probably because clinical maneuvers were described when it was believed that only dislocated dysplastic hips existed. Nowadays, with the introduction of ultrasound method in some countries, more dysplastic hips are detected earlier and more dysplastic hips are treated well. So universal screening seems to be the ideal way to screen all the babies. The aim of hip screening is to reduce the incidence of late presenting hip dysplasia without causing any harm, as for an overtreatment or an avascular necrosis. So here's the important thing. A well-standardized ultrasound method has proven not to create an overdiagnosis, so overtreatment do not exist. This is very, very important. I want to make clear in this point. With this, universal ultrasound screening should be implemented all around the world. The main problem of ultrasound screening is that we have many techniques. The graph method, which is the oldest one, is based on static coronal view, which includes a 7 anatomical structure checklist that must be seen and 3 landmark checklists to create a standard plane. This makes this method quite difficult to use it, but it's the most standardized and most helpful of the 3. The other ones are the Harkey and the Turgeson methods that use the concept of the femoral head coverage, including dynamic or not dynamic stress maneuvers. So this seems a completely Babel tower. Many languages, many techniques, and this means a lot of mistakes. It is very difficult to find the center of a non-spherical object. And as the femoral head is not round, with the rotation, each section of the head will have different sizes. So this is very important because with the Turgeson and the Harkey method, we use dynamic movement, we use dynamic screening, and femoral head is going to have a lot of centers. So these 2 different kind of methods are going to fail. So how to implement a screening method without a universal consensus in limited challenge countries? That is the big question. That is the question of this talk. But I think this is not a problem only in limited resources countries. This is a problem of all the world. Even advanced economical countries have this problem, and we need to get into this. We have a very big problem. This is a public health problem all around the world, and a universal screening will be helpful. The World Bank and the United Nations recognizes 195 countries. 79 countries are considered middle or high income countries, and the rest is considered a low income countries, which by the way of this talk, it's considered resource limit countries. This means that probably from these 79 countries that are middle or high income, we can thought that at least 50% of them are using a universal screening with ultrasound. But surprisingly, there's only 3 countries that are using a universal ultrasound screening nowadays: Austria, Germany, and Mongolia. That's amazing. Mongolia is leading this technique with the ultrasound screening method. So why Mongolia? Mongolia initiated the universal ultrasound screening 4 years ago after corroborating in 2011 then more than 0.6% of all the newborn babies had clinical undetectable hip dysplasia, that it was clearly seen with the ultrasound method. All these babies got an early treatment and they got mature hips after treatment. Slovenia which is not a country using a universal method, uses it in a region called Maribor. And they found that with clinical examination, more than 1.1 of the hips were undetected compared with ultrasound screening. The final result was the decrease of late dysplasia from a 2.1% to a less than 0.03%. So this is amazing. Now, what's happening in other countries? Latin America, it's formed by 21 countries of Spanish and Portuguese speaking language, but only Chile and Mexico are using universal screenings. Chile is using an X-ray universal screening since 2009, and Mexico has developed the universal screening with X-ray or ultrasound since 2016. So it's very early nowadays to know if this is working for us. The rest of Latin America doesn't have a universal screening, and that's a shame. Since 2009, a mandatory hip X-ray into all babies less than 3 months of age was installed in Chile, and they found that they really decreased the incidence of major procedures to a less than 0.18 per thousand lip births. But this is a big goal for them. Mexico doesn't have yet the record for these babies, but we think that we will have it by late of this decade. What's happening now in this region of the world? The Pan American Health Organization, in accordance with these 21 countries, are creating the hip dysplasia universal screening guidelines using the graph method. And why this method? Because this is the most accurate method nowadays. 2 weeks ago, we had the first Latin American graph method course held here in Mexico, and I think it was a complete goal. We trained more than 40 Spanish-speaking doctors from all Latin America, and this is the first step here in Central and South America region to deal with this problem, to deal with hip dysplasia. If we know that using an ultrasound screening method will decrease the incidence of late hip dysplasia, we will be healing more babies, and we will be getting healthy people. So in conclusion, universal ultrasound screening decreased the incidence of late hip dysplasia and major treatments. Imperative need of a standardized ultrasound technique, it's needed. We know that graph method is the best one, but we all around the world have some fear of using it. If we understand the method, we're going to be very helpful to our patients. And limited resources and high-income countries need a universal screening method. So this is why I put this in your hands. I want you to know that universal screening method with an ultrasound maneuver is the best way to detect hip dysplasia. And we want more people to be trained in these screening methods. Thank you very much, Pablo, for your invitation. I hope this is very clear for all of your audience, and hope to see you next year in New York.
Thank you so much, Carlos. Yes, I think you framed that question very nicely and gave us that introduction. We do have a few minutes for some questions on this first part. And again, I'd like to encourage anyone in the audience to put your questions in through the app. That's the best way to do this. If you click on the Q&A on the app, you can put your questions in, and we'll try to get to that. We do have a couple of interactive polls coming up, which we would also hope that you will join us in answering those as well. Carlos, you mentioned one thing, which is access to ultrasound, which is something I hear very often in all of the world, but especially in Latin America. And I heard this argument in Chile years ago, where they, as we'll hear from Dr. Birrer shortly, but they've effectively established this radiographic image. And you mentioned that you think ultrasound is a better way to diagnose this. So what are the barriers to people using ultrasound? We know that ultrasounds are cheaper, more accessible, and have no risk of radiation. What are the barriers to people obtaining ultrasounds instead of X-rays?
You know, Pablo, one of the most important things that I hear every day, it's that people says that ultrasound screening is a double operative dependent method. And this is not true. Even the X-ray, it's operative dependent. You know, it depends on the people who takes the X-film and depends on the people who interpret it. The ultrasound method, I think it's easier because you are doing this method and you are doing the interpretation. If you learn how to do a good ultrasound screen, it's going to be easier to diagnose a dysplasia. People is afraid of using it because there's not a consensus all around the world, and probably because graph method, it's a little bit quite difficult to understand it at first line, but when you understand it completely, this is very easy way to use it. So I think we need to get involved in ultrasound methods. It's going to be easier to diagnose a hip dysplasia more than using an X-ray. The other thing that I hear so often is that it's very difficult to get into a US machine, an ultrasound machine. But we have talked this when we were partners here in Mexico. We were talking it that if in a hospital it's a gynecologist, there's an ultrasound machine. And if there's an ultrasound machine, yet you can do it, this screening. So I think there's no a reason why not to do an ultrasound nowadays. It's 2021, so ultrasounds are available in all around the world. It's a cheaper study, and I think it's pretty usable.
Yes, I would agree. Thank you for that. I'm going to call on Teddy Slongo, who I see is in the room, and I hope maybe he can unmute because he just put a comment in the chat, which is quite true, that in Switzerland, they've had a very effective screening program for almost all babies. But Teddy, you've traveled around the world and you've seen this as well. What do you perceive as the barriers? Why haven't we been able to replicate? I recognize that, of course, Latin America isn't Switzerland, but you would think that with 30 years of doing this, we would see greater inroads into allowing some form of universal screening, even in resource-challenged countries. Teddy, are you there? I see him, but I don't hear him. There he is. Teddy?
Yeah. Sorry. Can you hear me?
Yes.
Okay. Yes, okay. Of course, this is different from country to country, but we started in Switzerland very, very early together with Graph, and our experience is very high. In the meantime, you know, these are not only orthopedic surgeons who are doing this. This is the hand of the pediatricians, and they have a very, very high level because they make courses, and really they make it better than the radiologists, and therefore really it's very easy to do this in the whole country. Of course, Switzerland is a small country in other countries, but in our country, it has shown that the screening is very, very effective. We made an investigation for our government because the government, the ultrasound is twice paid by the government. And then the government was thinking, oh, is this really cost effective or not? But to neglect hip dislocations are more expensive than the whole cost for our country for ultrasound. So it's very effective also from the cost side. And in my hand, over the last 20 years, I never have seen again a neglected hip. Absolutely not. All hips I see neglected, they are coming.
I think we lost Dr. Slongo, but and I appreciate that he's actually traveling right now, but we'll get back to him a little bit later on. We do have one more minute for me to ask Dr. Vidal. There's a few questions that have come in. So the questions basically relate to the learning curve with ultrasound and how difficult it is to establish this. So Carlos, can you tell us a little bit about how effective it is? How long does it take someone to learn to do ultrasound?
Okay, Pablo, this is a great question. You know, it's very easy to make this curve. You don't need to make 100 or 200 ultrasound screenings to get into this method. The thing is that we need to understand how to read the image. There's a very well standardized points to do this method. The first of all is that we need to find 7 anatomical structures. And if we don't find these structures, the image is useless. We don't need to use this image. The second one is to know that we need to find a standard plane. So this is why we're going to have a great image that all around the world we can read. If I make a graph method screening and I send you the image, and if you know this method, you're going to read it perfectly well. You're going to trace the lines, and the alpha and beta angle are going to be more reliable. But we need to take some courses. It's not so easy just to read the book or just to read some papers and learn how to do this method. You need to train, you need to be trained, and the courses are very helpful to this. You know, a few years ago, we thought that we were doing graph method by just looking or searching for the femoral head, the acetabulum, and the labrum, and we traced the lines with these 3 landmarks. But we need a standard plane. We need to be in the central point or in the very, very center of the hip to trace these lines. If we understand that we need to find these 7 anatomical structures and these 3 landmarks, we are going to be on the inside of the hip in the very center, and we're going to have more reliable images. So I invite you to take some courses to assist to courses to be trained, and the curve will be easier to reach. If you are on your own, the curve is going to take more time, and probably this curve is not going to be reliable. You're going to fail. So as anything or everything in medicine, you need to be trained. You need to be trained to do a screening method in every part of the body, and you need to be trained to do some surgeries. So for screening method, you need to be trained.
Excellent. Thanks for that, Carlos. We are going to move on. Thank you for that. And we will begin with our next session now. And we're going to hear the Chilean model for screening, 50 years of success, from Estefania Birre. If you could pull up her talk, and I think that's recorded.
Are we able to diagnose the entire spectrum of pathologies with just physical examination? Yes or no? I'm Estefania Birre, and I work at the Universidad Austral de Chile in the south of my country, in the city named Valdivia. My talk is about the Chilean model of screening. With this view of the world map, I'll invite you to know better the reality of my country, Chile. We are one of 13 countries in South America, located on the lower Pacific shore of the continent. The Chilean population in 2020 was 19 million inhabitants, and in that year, 210,000 kids were born. The incidence of TDAH in Chilean population is 3.9%. That means each year, 8,400 children will have the disease in all its presentations. The incidence of dislocated hips is around 0.1 to 0.2%. Active search for hip dysplasia is needed because this disability can be avoided with low-cost health policies. Developmental hip dysplasia has a wide spectrum of pathologies, from mild hip dysplasia to hip dislocation. Everybody knows that an early diagnosis will take you to a high success with orthopedic treatment or minor procedure. So, Any doubt about screening? In Chile, since 1970, the Orthopedic Surgeon Society was aware of that, so they taught in every medicine school that DDH must be searched actively. So nurses, doctors, and any health provider knows that it's a big burden not to diagnose DDH on time. Nowadays, we look for DDH with ultrasound at first month of life or the radiograph at 3 months of age. These images are insured by law, and it's called Explicit Warranties in Health. This law was enacted on 2004 and started with DDH on 2009. This law protects every newborn in the country, so it's universal. The age of 3 months was chosen to obtain the screening radiograph for hip dysplasia, as it's the earliest moment that allows for assessment of a mild dysplasia or unstable hip with this method, given the acetabular ossification process. An ultrasound at 4 weeks of age to avoid repetition of the examination due to physiological immaturity. The law not only provides to any newborn in Chile the chance to have good images from their hips, in case you have DDH, also provides the treatment and the follow-up by an orthopedic surgeon. The general objectives of this law is to guide the early detection and treatment of DDH in infants, particularly those with risk factors. Also to improve the functional ability and long-term quality of life of people with dysplasia, and also to reduce the incidence of degenerative joint disease, pain, and mobility limitations of the affected hips in these patients. How can we measure this success? The way you can prove that your health policies are working is by measuring the rate of hip major procedures like open reduction, pelvic osteotomies, and femoral osteotomies. In this study that we published in 2021, we investigate the results of the DDH screening program in Chile. Patients born between 2010 and 2015 were evaluated during their first 5 years of life. The number of major procedures like open reduction, pelvic osteotomy, femoral osteotomy, and the numbers of minor procedures like closed reduction, hip spica casting, adductor tenotomy. During the study period were compared, and ages at the first procedure and patient sex distribution were analyzed. The incidence of major procedures was 0.18 per 1,000 newborns. Several studies show the incidence of major surgical procedure with clinical surveillance, and our incidence is 4 times lower, but we double the incidence if we compare our results with universal ultrasound screening programs. We consider that the Chilean national DDH screening program is appropriated for use in regions with healthcare system with limited resources, that the screening procedure is reproducible, and that it yields substantial public health benefits. In the 21st century, with all the advances in health and technology, we cannot accept cases of dysplasia not treated in a timely manner, or a limping child that becomes a limping adult. Our goal throughout Latin America society is to at least have a universal screening program, timely, with good quality, and affordable. Thank you for your attention, and thank you for the invitation. All these symposia and courses improves our patients' lives.
Thank you so much, Estefania. That's a true success story, and I'd love to pick your brain in a little bit once we get to the Q&A about this, because I think you've clearly and very elegantly demonstrated how successful it's been. But we are fortunate enough to be joined by Kishore Malpuri, who I appreciate joining us at 5:30 in the morning out in Vancouver. And he's going to tell us a little bit about the screening realities in 2021. And as much as we can say that we'd like to have universal screening and that the ideal methods we know are present, he is someone who has traveled the world and can give us some perspective on what the reality is worldwide. Kishore, thanks so much for joining us, and you can take over.
Hello, greetings from actually PEI. I'm an hour ahead of you, so I'm all fresh. So thanks, Pablo. My first meeting that I've traveled in 20 months. Glad to be traveling. So greetings from the East Coast of Canada. If you haven't been to PEI, an amazing island that I suggest that you keep that in your future travels when we're able to travel. So without further ado, thank you, Pablo, for inviting. I think this is a great educational effort in reducing the burden of hip dysplasia globally. So DDH screening can sort of range from no screening to, as we're talking about, universal ultrasound screening or clinical screening, which we expect everyone around the world to do, or to high-risk screening. So if you look at what's being done, there's a lot of discussion around how to screen and what to screen, starting from this Pediatrics publication of clinical practice guideline to number of papers that are published over the years, including some randomized controlled trials that talk about what kind of screening is required. And as you can see here, some of these are fairly large, and they talk about a very low rate of late diagnosed DDH, irrespective of what kind of screening method that you end up using. And then there is this Cochrane review that's published, and this amazing paper that's done from Boston that really looked at decision analysis. The conclusion from all of these at that point in time is that there is no rule, especially when resources are strapped, for us to be thinking about a universal ultrasound screening, but definitely it warrants high-risk screening. And then we were fortunate that American Academy of Orthopedic Surgeons decided to spend a lot of money and 3 meetings, assembled 25 people from different societies together to come up with a guideline. But what came out was more than a guideline, actually, all the gaps in knowledge that were there in actually our understanding of DDH and its screening and what treatment is required, even for early management of DDH. And what's really important is this focus, especially popularized by IHDI, and thanks to Chad and his efforts, really bringing swaddling as a risk factor and bringing attention to the world that you need to pay attention to swaddling. And so in the end, the key messages are, what are the different risk factors now that now hold the test of time? Is family history of DDH, breech presentation. This next point is really important. It's history of instability. So if you're referred by a GP or a pediatrician or a primary care provider, even if they say it's a click, because often they cannot distinguish between a click and a clunk, that is a history of instability. And that is an important enough risk factor to keep in mind on swaddling. And universal ultrasound, even though we've heard several arguments why that's important, still remains controversial, as we have many other health priorities in systems like ours in Canada, where healthcare is universal, for us to actually have every single child screened, and it's a false positivity rate, which I'll come to that in a minute. And now what is really confusing is the spectrum of DDH that we talk about when people talk about incidence of DDH. This amazing paper by Randy Loader really draws attention to that. And if you take a look at this, how people have talked about incidence of DDH, you distinguish this into 3 different eras, where it was arbitrarily estimated, or was estimated by physical exam, or more recently, we estimated by ultrasound. Where we don't break it down is when that ultrasound is done. And if you look at this, and go on to look at what is the difference in terms of incidence, it's all over the map between different countries. It seems like in India, incidence is low because people carry them on the side. It's because they're not diagnosed till very late, and they're not diagnosed for a long time. And if you look at this paper from UK that talks about prevalence of dislocation of DDH in Britain over the past 1,000 years, very provocative title. And you look at that, they clearly talk about the incidence being different from when that ultrasound is done and when you diagnose. So obviously those that have universal ultrasound screening, and if they're screening within the first 2 weeks, they'll find a higher incidence of DDH versus someone that's screening them at 6 or 8 weeks of age. And other important, I think, contribution for us to be thinking about between IHDR and IHDI is the spectrum, DDH severity spectrum. So you can have from mild dysplasia to dislocated reducible hip. And each one of them is a different beast by itself, and it requires a different strategy in terms of its treatment. And our literature is filled with people talking about DDH in very different degrees of severity of spectrum. But it's also important to understand the regional differences in when they're actually diagnosed. In our original IHDI study that involved only countries from the West, our mean age of diagnosis was around 3 or 4 years of age. 3 or 4 months of age. And when we added countries like India and China, the mean age there is very different. And so you can see here, the mean age is about 4 months in the West, and India, it's about 31 months. So quite different. And those of us that are here talking about solving a global problem, we really need to think about our combined population of the speakers here that are representing the countries versus the countries that are not represented. It's a huge issue where we really have to think about how can we be more relevant to the 90% of the world we don't live and practice in, where the burden of hip dysplasia is probably 10 times greater than what we find here. And this classification developed by IHDI could be quite useful in places where there are no ultrasound, but this requires to be validated against an ultrasound. And we're working with our friends in Europe on trying to do that. And we're also working on developing care pathways for country specific, because some of their geographic needs and their systems are very different. This effort with India, we brought together 7 large societies with a combined membership of 120,000 medical people. And they've come up with their first care pathway in India for DDH, and that's just the starting step. And as we have heard, and I know Pablo uses this quite a bit, I think these could be some of the future directions where people say they don't have access to ultrasound. With artificial intelligence and with processing, we might be able to help them with that. And this network that we're trying to bring together, all of the different pediatric hip conditions together, as you can see here, very many different hip conditions that we have, and bringing all of the hip experts to collaborate could be the way to go to really address some of these global issues. Thank you.
Thanks, Kishore. I think that was a great way to round out these talks we've been listening to, and I hope you'll be able to stick around for the Q&A. But before we get to that, we will hear from Jim Castor in Boston, who again I've asked him to tell us lessons learned in 30 years of treating hip dysplasia.
Good morning, good afternoon, or good evening. It's great to be here, Pablo. It's actually been about 40 years, and I'm not sure I can tell you about experience. I hope I can tell you about judgment, and I'm not sure you'd say there was much wisdom in this, however. What I have learned, I would say, I'll start with a bit of a summary. Generally, developmental dysplasia as opposed to congenital is a correct term. Hip screening programs are highly beneficial, and ultrasound has contributed tremendously to our knowledge. The Pavlik harness isn't perfect, but bracing is highly effective in the management of DDH. Surgical management these days is much less frequent with better screening, and it should be concentrated in very experienced hands because there are much fewer cases. Follow-up is critical and at times humbling. And Ponseti was right about extended acetabular remodeling. The fetal hip development, I think, is important to understand. Lee and Jarvis in 1992 published on this, as did Strayer in 72. Recently, I've had an opportunity to look at ultrasound in fetal hips, and it gives a window into hip development that's important. Diaz further commented on the development of the acetabulum, that's a deep cavity initially becoming shallower at birth. The femur and the acetabulum form from the same mesenchyme. There is a mass of tissue then in which at 7 to 8 weeks a cleft develops. This leads to a deep cavity within the cleft, and the hip joint forms by 11 weeks. If we look at an ultrasound of this, and this is an ultrasound of a fetus at 24 weeks, seen in our fetal hip program, or excuse me, our fetal program at Boston Children's Hospital. I have an opportunity to diagnose almost all club feet and almost all limb deficiencies by ultrasound. It gives us an opportunity in many fetuses to look at hip development. These images have an almost normal appearing hip at 24 weeks. If we look broadly at over 500 hips, fetal hips that we observed, ranging in fetal age from about 17 weeks through 40 weeks, we see a consistently normal alpha angle and very well-developed hip. Fetal movement and force is necessary to develop a normal hip. The fetal growth and the hip becomes increasingly constrained as the fetus grows. The acetabulum then becomes shallower in some of the children and a femoral head less spherical, and the hip joint becomes less stable in the perinatal period than it was in early fetal development. There are some hips, however, like this one. This is a child as seen here with a dislocated knee. We know that there's an incidence of dislocated hip associated with dislocated knee. We see on the opposite side from the dislocated knee, a normal hip development, and this is at 22 weeks. And we see a fixed dislocated hip on the ipsilateral side. This can be confirmed on MRI. This would, I think, be what has been called traditionally a teratologic hip. When this child was born, they have a fixed high dislocation, irreducible, and very limited motion. There is a subset of dislocated hips then that are this early fetal dislocation with very different development. Be aware of this. Does late dislocation exist? Ilfeld and Weston many years ago suggested that it did. They did this based on X-ray follow-up. This particular infant or child at 2.5 years of age was seen with this dislocation. The older sibling had a dislocated hip. They lived in the Middle East. Imaging was done at the time of birth. This child presented with a limp, with full abduction, and this hip at age 2.5, despite early screening. Ultrasound has been used to identify early hip dislocation. High-risk infants, breech infants are screened in many countries, universal screening in some. This was a case that was given to me by Charlie Johnson. Ultrasound screening done showed these images at 1 month of age. Dynamic examination was done and was reported as normal. At 1 year of age, this child presented with a tight adductor, dislocated hip, as can be seen in the x-rays, and a diagnosis of DDH. At University of California at San Diego, where Salil is, late dysplasia was reported after normal ultrasound in breech babies. So late dislocation does exist. Instability does exist. There are factors that may lead to postnatal dysplasia. These include swaddling, maternal relaxant, position or positioning, and late intrauterine contractures. Also genetics that may lead to instability and dysplasia. Another thing that I learned was the use of the abduction brace in Pavlik failures. We don't have to necessarily move to a cast or cast immobilization. I'm looking forward to hearing from Salil on this, or from Woody on this subject. In the cases where we were successful with an alternative to a Pavlik bracing, they had inferior instability, all were breech, and hyperflexion was not a key to reduction. At times, DDH is unpredictable. In this baby treated with a Pavlik harness at 7 months of age, one can see a hip that is subluxing. At 9 months, it is still widened. The family said they had to return home to the Middle East and they would come back for follow-up later. At age 4, a perfectly normal hip, which I would think would be unlikely in the absence of treatment, given the findings at 9 months of age. Another case demonstrating the mystery and need for follow-up. Rather mild subluxation of a hip, rather normal ultrasound at 4 months of age. 2 months later, an x-ray shows subluxation. At 9 months, we thought we had won. Further follow-up leads to further instability, subluxation, and surgical treatment. So follow-up is always required. And when you expect a successful outcome, sometimes you're surprised by failure. And other times, you're given the gift of an outstanding result. It's humbling. Is Avian a problem? Yes. It's variable in closed reduction series. It was 20% at our institution, and most of these were type 1 in closed reduction. Stu Weinstein's series has 15 to 20% in the 200 hips that were reported. We'll probably hear something about this. Experimentally, in a pig model, as seen here with abduction, using MR and gadolinium, we can show normal perfusion that is shut off with hyperabduction. Because of this, we tried to use this in closed reduction monitoring using gadolinium as a predictor of avascular necrosis. It was not as accurate as it was experimentally. Young Joe has published a paper on this, but in those cases that had global decrease in flow, it was predictive of avascular necrosis, and it was helpful for us in 3D imaging. We're continuing to look at this and flow studies in predicting avascular necrosis. Acetabular growth continues from rim and triradiate. A stable femoral head location stimulates growth, and AVN may lead to lateral growth disorder in the femoral head and acetabulum. Follow-up is always needed. There's marked improvement in the understanding of DDH, gratifying decrease in the number of late dislocations. Bracing can be highly effective in DDH, and concentrating surgical experience seems very beneficial to me as the number of cases go down. And this has led to Young Joe Kim and our HIP team, as well as Mike Millis, doing the surgical results and really doing exceedingly well with it. Thank you very much.
Thanks, Jim. That was outstanding. I know that I am an outlier because I think about hip dysplasia every day, and I have been for the last 15 years. But I definitely heard a lot of wisdom in that talk, and I appreciate listening to all of these comments. We do have a couple of minutes for questions, and I'd like to start with Kishore, because there's a couple of questions referring to who does the neonatal hip exam. We know that training for this isn't always universal and isn't always standardized. In the UK, they've shown that the incidence of late presenting DDH hasn't actually gone down despite having universal screening by physical exam. So how do you improve on this?
So I think that's a great question. And I think we can look no further than BC. So we had our orthopedic surgeons, legends, that Mike Bell and Steve Treadwell used to go to a nursery and do physical exam themselves on every single baby. And they've shown that incidence is very, very low in their exam. But what they added was, they realized later on, they created a whole bunch of, at least in the current COVID rules, it won't work. They will literally line up all the babies and examine hips one after the other. And we can't do that anymore. Stop doing that. And we do have the incidence is more than I think what it used to be. So there's no doubt that you need to have some expertise in that. And that's where we need to do a better job of training them. And we need to come up with better education modules, either through VR or VA. It's not easy to find those dislocated hips for them to practice and be good at. We need to come up with better simulation ways of training our primary care physicians. So the other question that followed was, click is not reliable. I completely agree, but I think AOS debated quite a bit whether to add the history of instability or not. And when they looked at all of the different studies that are published at that point in time, someone that referred to you with a click, because you can't differentiate with a click or clunk. Whenever you design a screening program, you always want to capture more. Like, you don't mind getting, quote unquote, I'm contradicting myself a little bit here, you don't mind getting some false positives, or you don't mind over referrals for you. And same thing happens whether we do screening for CP, for hip surveillance, or hip screening. We order a lot more x-rays than what we find. So that's why the click is added as click or clunk is added as history of instability. I don't think, Pablo, we have it perfect yet about how to train our people. I think that's why we know with the risk factors where the incidence is much higher, we need to advocate for at least selective ultrasound screening. I do see in countries where that can afford, that can do it, a rationale for universal ultrasound screening. But the question is when, and when are you going to do that? Are you going to do it at 2 weeks? Or are you going to do it at 9 weeks? And you will find a lot more hips that are positive at 2 weeks versus 9 weeks.
Yes, thanks, Kish. Good points. We are a little bit over, but I have a quick question for all three of you, Estefania, Kishore, and Jim, and try and keep this a quick answer, because this comes up often. What constitutes a late diagnosis? So I'd like you to give me an age, because when I was practicing in Mexico City, the mean age of patients who would present was after walking age. And I know that in Norway or in Australia, they consider late presenting DDH to be much earlier than that. So what constitutes a late diagnosis? Estefania, can we start with you?
Thank you. I think we have to say something about diagnose before we say about late diagnosis. So I think early diagnose is 1 month. Timely diagnose is before 5 or 4 months. But late could be after 6 months, because we can't achieve a good result with only orthopedic treatment, and we're going to deal with residual hip dysplasia. So it's a thing that we have to discuss. But early, it's around 1 month. Timely. Okay, yes. I like that definition. Concepts, but it's the same thing. And as you know, we have some different problems. It's better to look at dislocation earlier than it could.
I like that definition: early, timely, and late. So, Jim, would you agree? 6 months is a late diagnosis?
I think that it may be a term that's it's confusing to try to say what is late diagnosis, because developmental dysplasia is really an evolutionary disease. And the implication is that it would always be diagnosable earlier if the term late is used. So that's a concern. I think most of the babies with instability and with a perinatal dysplasia are going to be diagnosed with ultrasound. And done very early, you get a high incidence of dysplasia. Some of that gets better on its own, as we see in the screening studies, and the delay or the recommendation that ultrasound be delayed until 4 to 6 weeks. So I would also say that there are some patients where if you use the term late, it would imply it could have been diagnosed early. I think it can be evolutionary in some cases of dysplasia, unfortunately.
I fully agree, and thanks to all three of you. I am going to give everyone a few minutes of break because we're a little late. Yes, go ahead.
Is it possible to make to say something here?
Could I ask you to save that because we only have 5 minutes of break, and I would like everyone to stand up and stretch. One of the things we found in the last year we've learned is that you get Zoom fatigue from looking at the screen too long. So if I could ask everyone to stand up, stretch, go grab a cup of coffee, and Carlos, we'll get back to your comments, but we only have 5 minutes of break. So thanks so much, but we'll be back at 10:10 on Prince Edward Island. So in 5 minutes. Welcome back, everyone. I know that was a quick break, but I would like to try and stay on time. Again, maybe I've been over-ambitious in the program, but it is crucial to try to stick on time. So we're actually doing quite well with that. So I'm looking forward to this next block, beginning to talk about the early treatment now that we've gone through some of the issues surrounding screening and diagnosis. And it's my absolute pleasure to present my friend, Salil Upasani from Rady Children's in San Diego, who hasn't been in practice for 44 years, but he was gracious enough to fill in for one of his senior partners, Scott Mubarak, and tell us about the experience with the Pavlik harness.
Excellent. Thank you, Pablo, and thank you for the opportunity to present this morning. As Pablo said, I haven't been alive for 44 years, but it's my distinct honor and pleasure to give this talk for Dr. Scott Mubarak. As most of you might know, he recently retired on the 1st of July and is now exploring the South Pacific with his wife and having a fantastic time. These are my disclosures, but nothing is relevant to this talk. The funny thing with Dr. Mubarak, you can always tell what decade a photo is from based on the height of his hair. So based on the size of that afro, I'd say this is probably somewhere in the 1980s. And around that time, this was me very excited that Dr. Mubarak had explored the Pavlik harness and had become such an expert with it because I was looking forward to learning from him over the years. So my task here is to talk about the Pavlik harness, and I wanted to put a Scott Mubarak spin on it by talking about all the amazing articles that he's published and the enormous influence that he's had on our program here in San Diego. So I'd say the Pavlik harness is the gold standard for the treatment of infantile DDH, and it's been the method of choice. It's been around for 75 years, described in 1946. And if you think about all the surgical techniques that have evolved over the years, it's amazing that this brace has stood the test of time. So I wanted to spend the next few minutes talking about why. So a little bit has to come from the man himself, Dr. Arnold Pavlik. So he lived from 1902 to 1962. And Dr. Mubarak and Victor Bielik published this paper in 2003, where they went back to Pavlik's home, met with his son, who's the third man here that Dr. Mubarak is shaking hands with, and got into the history of when and how this brace was developed. So just to give a little bit of historical perspective, Adolf Lorenz in 1896 described closed reduction and plaster casting. This was a very forceful reduction of the hip, and he had a very high risk of avascular necrosis. So people were looking for different, less aggressive methods of getting the hip reduced. Just to put things into reference, X-rays were described in 1895. So this was right around that time period when dislocated hips were diagnosed, and we could follow their evolution over time with X-rays. So the Frika pillow was developed in 1941, the von Rosen splint in 1962. So in between those, Pavlik was born in 1902 in Czechoslovakia. He had gotten his degree in 1930 and joined Frika to practice in Brno. He actually developed the harness during World War II. So during that period, between 1939 and 1945, he initially started making the harness out of wick material because there were leather shortages during the war. And then he finally described it at the Czech Ortho Society meeting in Prague. And more than just the harness itself, I think it's primarily focused on his concepts of a functional treatment for a dislocated hip. So the key principles that he liked to focus on was to maintain the hip and knee inflection and abduction, maintaining motion so the child actually determined the level of abduction of the hip. And he emphasized dynamic, gentle, and a simple approach to getting the hip reduced, in contrast to the aggressive closed reductions. So he published a series of 5 articles in the 1950s, and his 5th and final paper really focused on, there were some attacks on him about this concept of dynamic reduction of the hip and the use of a harness. So he tried to address his critics in his final paper. So it's amazing that it's even, left Czechoslovakia and got out to all of us, because I'm sure most people on this panel are currently using the Pavlik harness, because it was developed under Nazi rule. His papers were presented in Czechoslovakia. No one really went out to visit him. And the news of this brace and this treatment reduction concept spread really slowly. But Dr. Mubarak gave me some interesting insights about how this was presented at a CCOT meeting in 1963, discovered by Dr. Blount, who promoted it to Dean McEwen, and then they brought it back to the United States and then published on its success and its use. So why is this harness so successful? I think primarily because it focuses on this dynamic motion of the hip, using hip flexion and abduction, the main straps that hold the hips in flexion and abduction to get the hips reduced, and then the child sets its abduction. So at Rades, it's currently the standard care, and despite when we diagnose the DDH, and despite where on the spectrum the DDH is, so dysplasia, subluxation, dislocation, the answer is always Pavlik harness. So it's interesting when I'm teaching residents and fellows, we go through this whole spectrum of disease and how important it is to diagnose exactly where they are, and then the answer at the end is always Pavlik harness. So there are some challenges with the Pavlik harness, and I wanted to kind of skip into that. So the goals of treating a dislocated infantile hip: the first goal is to get the hip reduced. The second goal is to keep the hip stabilized. The third goal is to correct any residual acetabular dysplasia that's present. And of course, to accomplish all of these goals without any complications, and primarily avascular necrosis or redislocation. So we use ultrasounds weekly until the hip is reduced, and then we continue it for about 3 to 4 weeks. And if the Pavlik does not work, then we definitely go on to other options, such as the abduction brace, which Woody's going to talk about, or going on to closed versus open treatment. Dr. Mubarak published this article, Pitfalls of the Pavlik Harness, in 1978, talking about all the issues that could go wrong. First of all, there is, some slight complexities to using this device, and proper education of how to apply it, placing the first strap at the level of the nipples, shoulder straps going around the shoulders, followed by making sure that the heel is back into the strap going around the leg, and that the strap is right below the knee in the crease, and then setting the hip flexion, making sure that the child is able to extend their hips to a 90-degree position, and then finally setting the abduction strap. So there is some getting used to it, and now we have some fantastic videos on the IHDI website to help parents. But despite that, we see kids in all interesting variations of how the Pavlik has been applied, with the first strap down by the belly button, crisscrossing straps in the front of the body instead of the back. So many, many issues that could go wrong. The other main thing to look out for, like Dr. Kasser had mentioned, that some of these hips can have teratologic dislocations or underlying disorders that aren't diagnosed early in infancy. So it's really important to find those, as they tend to be the failures of the Pavlik harness. And finally, the parents as well. So this is a funny photo of Dr. Mubarak's son, who was not very happy of Scott applying the brace on their child at the time. But it's very common to get parents who are, questioning your treatment strategies and, placing their beautiful infant into a harness at a very young age. So it's important to work with parents, have a system set up where your nurses can spend extra time with them, educating the families on how to apply these harnesses. And then finally, the physician. So, sometimes we work too hard to try to get the hip reduced. And if we flex the hip too high, we have a risk of getting a femoral nerve palsy. And if we place too much abduction on the hip, there is a risk of avascular necrosis. So it's important to set that amount of abduction. I think in the interest of time, I'm going to skip through some of these slides where we talk about, diagnosing hip dysplasia in breech babies. We always get an ultrasound at around 6 weeks of age and then follow up with an X-ray at 6 months of age because some of these studies out of San Diego have shown that there is residual dysplasia that can be identified. And then our protocol for using an ultrasound has improved our ability to diagnose and treat these Ortolani positive hips and improved our success rates from the mid-80th percentile into the 90th percentile. So I think it's really important to follow kind of a consistent methodology for following these hips as they get reduced and they continue to improve over time. Perfect, Pablo. I think I'm going to stop it there for you to keep everything on time.
Well, thanks, Salil. Yes, I think you've condensated a lot of knowledge into that very quick talk, and you're a very worthy follower of the San Diego method, and I think Scott Mubarak would be very proud of you. So thanks for presenting that. But we know that the Pavlik harness doesn't always work. The Pavlik method isn't always successful. And this is always a conundrum. This comes up frequently with my residents. What do you do if the Pavlik fails? So with that, I'm going to hand it over to Woody Sankar, who is just down the road here in Philadelphia, who is going to tell us what to do when the Pavlik fails.
So thanks for the opportunity to speak today. Hopefully I can take control here. All right, my disclosures are really not relevant to this talk. As you just heard, the Pavlik harness is the most widely used device in North America for treating DDH, and success rates for mild dysplasia are nearly 100%, while the success rates for true dislocations are a little bit more modest, around 70 to 90%. So the point here is that a discrete minority of dislocated hips will fail treatment, and early recognition of this issue is important because persistent use of the harness in the face of a dislocation can result in the so-called Pavlik harness disease, which can complicate subsequent treatment. So there's several reasons for why a Pavlik might fail, and the bulk of this talk is going to focus on these different mechanisms and how to deal with them. So reason number one is improper harness fit. So as you just heard from Salil, obviously the harness is only going to work if it's fitted right. Preemies and neonates are often too small for even the smallest harness, and sometimes you have to delay treatment until they're a little bit bigger. At the other end of the spectrum, although they've had success in San Diego, many people start becoming a little bit more reticent in using a harness over 6 months of age because the infants are larger and they can kind of overpower a harness. So in any infant who's failing treatment, you got to make sure that the fit is accurate before you abandon treatment. So as a bit of a review, because you already heard this, there is a design to the way the Pavlik harness is set up. The chest straps should be positioned at the nipple line by adjusting the height of the shoulder straps. The anterior straps set the amount of hip flexion, and they should run along the anterior axillary line. They usually position hips in about 90 degrees of hip flexion. And the posterior, the abduction straps run posterior to the thigh, and they should not result in forced abduction, as this can increase the risk of Avian. Reason number two for the Pavlik failure is poor patient compliance, as close follow-up and ultrasound is really needed to monitor progress and adjust the harness accordingly. Obviously, this is not a factor that's entirely in our control as providers, but patient education and empowerment is really important to help improve our outcomes. Femoral nerve palsy can be a reason for Pavlik failure, and this has been associated with excessive hip flexion in the harness. The Texas Scottish Rite study published in JBJS reported the incidence to be around 2.5%. Risk factors for this series were larger, heavier infants, as well as increasing disease severity. Now, all the palsies recovered, but the time to resolution varied significantly, as you can see in this bar graph. The presence of a palsy has a major impact on Pavlik success. So 47% of those with femoral nerve palsy were successfully treated with a harness compared to 94% of controls. And the time to resolution affected the eventual success rate of the harness. In order to maximize the chances of the Pavlik working, the authors recommended that you try to adjust the harness to less flexion or just temporarily halt the harness rather than getting large gaps in treatment that can really affect your outcomes. So reason number four for why the Pavlik might fail is persistent dysplasia. So in the setting of an adequate reduction, this may not indicate failure of the harness per se, but rather insufficient length of treatment. The alpha angle on the initial ultrasound is shown to be predictive of the risk of having residual dysplasia down the road, and prolonged management of both the harness or brace may be needed to completely resolve vestibular dysplasia in certain infants. However, this can be hard with the advancing age as children become more mobile and parents start to fatigue of treatment. A study out of our institution found that part-time bracing can be effective for improving vestibular indices in older infants. Keep in mind that the prevalence of residual radiographic dysplasia, even after successful treatment, has been reported to be anywhere from 5 to 30%. And so, as you've heard already today, most of us recommend radiographic follow-up throughout growth to monitor for this. Reason number 5 by which the Pavlik may fail is if the hip won't stabilize, even if it's reduced. So this may indicate insufficient length of treatment or inadequate rigidity of the device. If you've been treating for a while and things remain unstable, consider an underlying ligamentous laxity condition or a syndrome. And also be sure you do indeed have a deep concentric reduction by double checking the ultrasound to confirm the absence of a structural impediment to reduction. If your reduction is good and the hip just won't stabilize, then you can stay the course with the Pavlik. You can consider a more rigid orthosis like an ill-felt or a plasticized abduction brace. Rarely, closed reduction and spica casting is necessary, and open reduction with a capsulorrhaphy with or without a pelvic osteotomy is really reserved for much older infants who have continued and persistent instability. The last mode in which the Pavlik may fail is if the hip won't reduce at all. And as discussed, this can occur in 10 to 30% of dislocated hips being treated with the Pavlik. Now, risk factors for failure include bilateral dislocations, irreducibility on initial physical exam, and increasing severity of displacement. Potential causes for failed reduction include extra-articular soft tissue contractures, mechanical blocks within the joint, and improper positioning in the device for that particular hip, or insufficient rigidity of the orthosis. Ultrasounds are extremely useful to identify the cause, as in this example, where we have an infolded labrum that's partially responsible for the persistent subluxation. As mentioned earlier, the harness should generally be abandoned after 3 to 4 weeks to avoid developing Pavlik harness disease, although occasionally I will go longer if I'm seeing some progressive improvement in the hip. At the end of the day, though, if the hip still won't reduce, you have to abandon the harness, and there are several other options that you can consider. So McLean described a modification of the Pavlik in which the posterior abduction straps are rerouted around the flexion straps to maintain increased abduction, and reported on 3 patients in which this was successful after failure of standard Pavlik fitting. The use of a rigid abduction orthosis for infants failing Pavlik has been described, but it's had mixed results in the literature. Hedequist out of Boston, along with Jim Casper, reported an 82% success rate with the plasticized orthosis following a failed Pavlik. But a follow-up study in Los Angeles by Ibrahim, however, found that abduction bracing was of no benefit. Our own anecdotal experience at the Children's Hospital of Philadelphia has been that abduction bracing can be quite effective for this application. So as a result, we designed and completed a study several years ago looking at a cohort of 28 hips with DDH under 6 months of age who had failed a Pavlik harness and were treated with the brace that we like, which is the ill-felt orthosis, and compare this to 22 hips that went directly to closed reduction and spica casting after Pavlik failure. In the end, 23 out of 28 of our hips in our bracing cohort were successfully stabilized with the ill-felt brace, with 3 requiring closed reduction and 2 in open reduction. Meantime, the ill-felt brace was 11 weeks, and there were no complications in this cohort. 22 out of 22 hips in the closed reduction group were stabilized, with 2 hips requiring an open reduction. And the mean time in the cast was 14 weeks, with most infants undergoing a cast change during the process under anesthesia. At 1 year follow-up, we found no significant difference between the 2 cohorts in terms of residual radiographic dysplasia. Interestingly, according to Salter's criteria, we found 3 cases of Avian in the closed reduction cohort compared to none in the bracing cohort. So our 82% success rate that we found with the ill-felt brace following Pavlik failure was consistent with Hedequist results and comparable to our own results following closed reduction and spica casting. Because of the ability to potentially have a lower AVN rate as well as avoid the burden of spica casting as well as the exposure to general anesthesia, we concluded that the ill-felt brace should be considered as the next line of treatment following failed Pavlik prior to proceeding with closed reduction and spica casting. So here's an example from our series of a 1-week-old infant. Here's what it looks like after 4 weeks in the harness. You can see the clear persistence of the dislocation. 2 weeks after being switched to an ill-felt, the hip has reduced, and by the end of bracing, the hip has normalized. Another option for a failed Pavlik is traction. This is probably best for overcoming extra-articular soft tissue contractures, like a tight psoas or an adductor. There are reports of traction being used after a failed Pavlik followed by reinstitution of a Pavlik. There are also several reports of traction being followed by spica casting and with good results. I've not had a lot of experience with this, and it's not performed a lot in North America. Another option, of course, for treating a failed Pavlik is a formal closed reduction and spica casting under general anesthesia in the operating room. This is typically performed with an arthrogram to judge the adequacy of the reduction and sometimes a tenotomy to help improve the safe zone of the reduction. If you have a true intra-articular block, however, or more severe soft tissue contracture, then a formal open reduction will be necessary. You'll hear a lot about this in the subsequent talks. This can be formed through a medial or an anterior approach. And again, you're going to hear more about this later today. So in conclusion, I'd say the Pavlik harness is generally successful, but failures absolutely do occur. Early recognition is important to try to avoid Pavlik harness disease. And if things aren't going well, consider the 6 mechanisms of failure that we talked about, as this can guide your potential solution. And there are several options after failure of the Pavlik, including rigid bracing, traction, and closed and open reduction. Thank you.
Thanks so much, Woody. I've heard you give variations on this talk many times, and I always enjoy it. So thanks for doing that. Let's close this block out with Oliver Berkey all the way in Australia. It's quite late, so thanks for staying up to join us and be with us and tell us what the current best practice is for late detected hip dysplasia in Australia.
Thanks very much. I cannot yet see my talk. This is not mine. It's a big challenge to talk about best practice being not 40 years in practice and also having 7 minutes. I think I'm still waiting for my talk.
Pulling up your slides.
Here we go. Thanks very much, Pablo, for the introduction again. So I'm trying to give in about 7 minutes some thoughts about my way of treating late detected DDH, as you asked me to, although I can't call it best current practice. I can only call it my try to do my best. My slides don't advance, unfortunately. Here we are. So I won't talk about the traction, close reduction, technical aspects of arthrogram, medial and anterior open reductions, the technical aspects of all the details that we'll have all those experts later talking about. I will simply go through my general protocol of late DDH, and in particular I'll talk about the issues and complications I look out for and how I try to manage those. Late has been discussed. What's late? I think from a management perspective, I agree with Estefania that 6 months onwards changes the protocol, and therefore this is what I consider late for my talk. And I'll go through with some examples through my aspects of management. I'll start off with the bracing, which I use in late DDH only if the hip spontaneously reduces in abduction or is already in. In a case like this, where a 9-monther presents with quite significant dysplasia, 35 degrees acetabular index, sleep time bracing over a year's time, which the patient tolerated well, led to an almost normal hip at age 2.5. So there is a role for bracing in late detected DDH, as long as the hip's in. If we have a case like this, where we have a 3-year-old presenting with a mild limp, the left hip subluxated, lateralized, Shenton's line is broken, it's a bit more severe. It's the question, what are we going to do? Is it, I think, quite obvious that the left hip is dysplastic enough to need a pelvic osteotomy, but with the subluxation, does it require an open reduction as well? And in a case like that, I use anterior ultrasound in clinic to see if the hip reduces in abduction. And if that's the case, we may be able to combine some bracing with an operation. The anterior ultrasound will be discussed later in more detail again and explained. And it basically is an axial cut, like an axial MRI, where we use an anterior ultrasound from the groin area. So in this case, after 6 weeks of abduction preoperatively, the arthrogram then showed the hip to be centered with no medial dipooling, no subluxation, and quite a large cartilaginous onlug, and therefore only a pelvic osteotomy was enough and was able to avoid intra-articular surgery in this case. The close reduction is something that I feel works rarely, only in over 6 months of age. I still try and do an arthrogram first, but often the arthrogram shows at an attempt of close reduction, a insufficient concentric reduction and or too much abduction is required to keep the hip in safely. This is a case where an MRI was performed after a close reduction attempt was done, and this arthrogram, despite being not satisfactory in my opinion, was accepted, and the MRI shows the infolded labrum, obstacles to obstruction, to reduction, infolded capsule even, and an unacceptable scenario where I think we have to proceed to an open reduction in order to have a chance to get a reasonable outcome. If we talk open reduction, the medial open reduction has the advantage of being able to reattach the shortened ligamentum teres for some stability at the remnants of the transverse ligament. But since it's been reported to have a relatively high type 2 Avian rate, I personally prefer doing an anterior open reduction through a Smith-Peterson approach, and in the younger children without a split of the apophysis, and then doing a careful capsulorrhaphy in avoiding tension on the supralateral capsule because that can compromise the femoral head diffusion, like we know from SCIFI scenarios and also from the nice postoperative MRI studies after close reduction. It also enables us to do a pelvic osteotomy, but that only comes into play in slightly older children. The walking age DDH I usually treat with an anterior open reduction and pelvic osteotomy. Sometimes femoral osteotomies are required depending on how tight the scenario is. This is a 2-year-old walking in funny. That was the referral from the GP. And this kid needed the works, was treated with bilateral anterior open reductions, femoral shortenings, and some derotation and bilateral pelvic osteotomies. We can get those hips in, but like also mentioned in a previous talk, it's not normal thereafter. And we look back over a 10-year period where 41 hips had enough follow-up of the late detected walking age cases, and almost half of them had a growth disturbance, and only a bit more than half had excellent outcomes at 5-year follow-up. And we're not even talking at 40-year follow-up. Whilst if we looked at the group of successful Pavlik Harness in early detected DDH, the success rate was 100%. So I perfectly agree with all my previous speakers that the outcome of the late detected DDH isn't great. And we need to improve that and get early detection and treatment for hip dysplasia. But so for the late ones that we have gotten in, we still have to watch out for those growth disturbances. And in particular, the Calamity type 2 lateral growth disturbance is a silent killer of hips because it can develop quite slowly and late and puts pressure on the lateral acetabulum and can actually get a hip that looks reasonable go backwards over time. This is an example of a 4.5-year-old, very ligamentously lax child with a unilateral hip dislocation was treated with an open reduction and pelvic osteotomy, which then was initially looking not too bad, but further down, when we look at the direction of the physis, it shows the physis is starting to get more and more horizontal, and the acetabular development is not progressing as hoped. And in a scenario like that, with the beginning of a type 2 lateral growth disturbance, I use a medial hemiepiphyseal screw to try and guide the growth back towards the cup. And you see the acetabular remodeling has quite nicely happened over time, and the physis is now in the right direction. In a case of more severe residual dysplasia and Avian, like this child that had a close reduction in spica age 15 months, I initially tend to wait and let them recover from the initial insult. And then in this case, after the growth disturbance had declared itself as, again, a type 2 Avian with significant acetabular dysplasia, a guided growth alone is not going to do it. And this child was quite reasonably covered after a varus osteotomy and a pemberton fixed with one screw in order to avoid a spica. But also down the track, these kids need continued surveillance, as I think the growth disturbance is going to continue even after our reconstruction. And so in this case, I tend to use guided growth after removal of the plate in order to continue the guidance of growth for further development. If we look at the late and residual dysplasia and deformity that often is a consequence of late detected DDH, I personally like pemberton osteotomies. I fix them with a screw to avoid a spica in older kids. I only occasionally use Salter or triple osteotomies, and we will hear a lot about the triple osteotomies down the track. And if it's possible to wait, I wait for the most powerful adolescent PAO plus or minus relative neck lengthening. An example of a pemberton, when the cup is steep and begs to be bent down, I do so. And even in age 6 patients, pemberton osteotomy can lead to quite nice results and resolution of the hip dysplasia. In a scenario of a rather acetabular insufficiency, where the acetabulum keeps about 30-40% of the slightly enlarged femoral head uncovered, I think a reorientation is required, and this can either be done with a Salter, like in this case, or with a triple osteotomy, which Teddy Slongo will talk about in a lot more detail later down the track. If we are faced with very severe residual dysplasia and growth disturbance around age 9-10, sometimes PAO or a Bernese triple are the only way of trying to redirect the acetabulum, and can be combined with a trochanter distalization in order to make room for the reorientated acetabulum. But in the younger children, we only do it if it's absolutely necessary, in conjunction with our adolescent young adult PAO surgeons, and we would usually wait until skeletal maturity and then do the PAO and relative neck lengthening if so needed. In summary, I try to do my best to manage each case on its individual basis, trying to safely minimize the amount of intra-articular surgery to keep the AVN risk low, and watch for growth disturbances. And if I see them, I consider guided growth techniques early, and then deal with the residual dysplasia and deformities. I thank very much for the invitation again, and apologies for some delays and lags in the presentation. The internet might not be the quickest today down in Sydney. Thanks very much, guys.
Thanks to you, Oliver. That was a great overview. Again, as you can see, we're getting into some of the nuances and how the spectrum of pathology really varies. We're not talking about the same condition all the time. I'm going to skip the next Q&A, which we had scheduled because we are a little bit behind, but I think we'll make up for it. And we still have, along the same lines, we're going to hear from one of my favorite people, Perry Schenecker, who is going to tell us about the pros for closed reduction and cast management and his experience with doing this.
Click down here. Pablo, thank you very much for inviting me. And this would be the pros for closed management and closed reduction and cast management. No conflicts or disclosures. What I have learned, I appreciate talking after Dr. Burke. This would be a point counterpoint. Too young, maybe there's anesthetic risk, unstable narrow safe zone. Watch out for Avian. Internet is slow here also. Lateral and very proximally displaced, as Dr. Eastwood has showed us, watch out for redislocation. And if you fail with a closed reduction, don't try another one, proceed with an open reduction. So my algorithm is, as we see, birth to 6 months, I try my best to get treated with a harness of some type or a brace. For me, open reduction is for the older children, 4 to 18, 24 months. I would consider a closed reduction. Of course, there's always overlap. So this is a 6-week-old post 3 weeks in Pavlik. Right hip is Ortolani positive. It is subluxed laterally and posteriorly. The left hip remains Ortolani negative. A problem for me with the Pavlik and it's dislocated on the longitudinal view and also posteriorly on the transverse view. So at this stage, we have laterally subluxed and laterally dislocated hips, and I would consider this patient to proceed with a closed reduction, and I would wait until the patient is about 4 months of age or maybe 11, 12 pounds, and then I tried my closed reduction. And when I do my reduction, everything depends on my feel of stability and reduction. It's the most important item during the procedure. Everything is what you see in front of you. The rest to me just confirms what we find. So in this particular child, we put the patient to sleep, and reduction of what we felt clinically was a stable reduction in both hips is confirmed with radiographs. And we see the pre, here we see the post. I like to write the Hilgenreiner's line on the x-ray as best as we can. You see the heads below Hilgenreiner's line, so both hips in this situation are reduced. The anterior posterior, or the arthrogram issue is, I think, controversial in smaller hips. Be careful, don't put too much dye in the hips, because I have destabilized the hip, as have others. If you put a little too much dye in the small hip, that's sort of a precarious reduction. I really like the post-reduction 3D imaging. In this particular case, it confirms to me that we can see things very nicely. As we do here, we can see the femoral head and the acetabulum very nicely. The reductions are confirmed, and we proceed then with further observation and cast changes down the line. So this is a 5-month-old failed Pavlik on the left side. As we see on the x-rays in the OR, sometimes detail is not that obvious, and we have to outline and try our best with the imaging available to look at the femoral heads in these particular hips, both after we draw Hilgenreiner's line, are reduced, and we have a comfortable feeling that this can be managed with a cast application and with or without your arthrogram. So the hips are seated. I applied the cast, but you'll notice when we applied the cast are inflection, abduction, but this cast is in air, I would say. I put it on myself because there's too much extra rotation. These patients have a lot of femoral anaversion. So here's my post-cast x-ray, and very much to our dismay, the hip is no longer reduced, but it is externally rotated and dislocated. So at that time, we put the hip back in at the same setting with internal rotation and flexion, and a reduction that we lost when we changed the cast was regained. So internal rotation and flexion, I think, is very important to me in stabilizing this very younger hip. Again, postoperatively, after the patient awakes, we get the MRI. I don't have availability for MRI in my OR suite, but the 3D axial view here is very satisfying to me that we have a stable situation. Follow up 5 weeks later, cast change, again, hips very nicely seated. And then we watch the hips. Follow up is very important with closed reduction, 1 year post-op, and 5 years, patients coming along very nicely. So the follow-up, again, is very, very important. A little tighter hip, 8 months old, Ortolani negative in the clinic, put the patient to sleep. Galeazzi sign is present. You can see the short leg. Closed reduction is possible at 50 degrees of abduction, a narrow safe zone. What is the safe zone? I think, as Ramsey and McEwen were mentioned before, very important to me to figure out how much adduction before I dislocate and how much abduction before I'm too tight. A wide safe zone is a very, very good thing to find when you do this. It's got to be going to be a success. Whereas if you have the narrow safe zone, be careful as to how much you abduct the hip. So the Ramsey-McEwen safe zone, I think, is very helpful. If you have a safe zone, you can get a little more abduction with an adductor tenotomy. So we've done the adductor tenotomy. We now do the arthrogram in this older patient. It's not perfect, but there is a reasonable reduction of the head, the labrum, the capsule, kind of a smudgy dipool. Reduction, okay, we thought so. We get the arthrogram and we put on the cast, then we take our 3D, and much to our dismay, sometimes on the 3D picture, we are not reduced, but we are displaced significantly posteriorly. The cast should be immediately removed. Make your decision on whether or not you want to try it again. If you thought you had it, I would try it again. Follow up on this patient is very important to make sure Avian doesn't occur. So here we're developing very nicely with splint laps at nighttime. Follow-up again is very, very critical until the dysplasia has resolved. What about the older patient, 13 months of age, but the hip is not that proximally displaced? Can this be closed reduced? I think it can. Again, the whole decision for me is made by what I feel when the patient's asleep. In this particular case, the patient had a nice safe zone of about 35 degrees. And so I was very comfortable with my sense of reduction. I confirmed that with the arthrogram. Excuse me. And the arthrogram in this particular case shows a very satisfactory reduction, very narrow safe zone, a very wide safe zone, but a very good arthrogram. So this to me is something that's going to work, probably 3 casts. Again, the 3D imaging shows us the quality reduction of the left hip, which is very, very comforting that this is going to be a satisfactory outcome. Follow-up for this patient is very important after casting. Here we are at 1 year, and we'll follow this patient until the dysplasia resolves or we treat the patient for dysplasia. Here's a patient we get in trouble with, a 4 months old, bilaterally dislocated. We think we can get it. We should be able to get it. After all, we're orthopedic surgeons. So we attempt to close reduction. It's not perfect. The left hip is too lateral and going a little proximal. So we try anyway, and we persist with our cast. And we then risk the chance of pushing the safe zone into too much abduction, and circulatory problems develop. And we get into the situation where we immobilize too much. So every time we get a chat, the chat is coming across my screen every time this is happening. Every time a chat comes up, sorry. So we immobilize in too much abduction, and we end up pushing the hip beyond the limits it can take. And so the Avian is a definite concern in this situation, which did occur. So this patient then followed up with us at 15 months of age. We saw him for the first time. And we now have a significant biological problem. Treatment recommendations for this will have to include, as we go on and follow up with trochanteric overgrowth and a probable leg length inequality. So here we have an older patient who presents at a year, very proximally displaced, bilateral problems. This to me is not a patient who is a good candidate for closed reduction. It's going to be one of those problems that we fail because we have two hips dislocated, both very proximal, and this should be done with an open reduction. So follow-up is very important, 7 months of age. And after closed reductions, you see the patient at 18 months. You could take various ways of treating this. I like to very early with this amount of subluxation before age 2 do a PFO. I think it works very well in this situation. Confirm a reduction and appropriate PFO. An older patient, 2 years of age, ortholani positive in the clinic. This patient reduces very nicely after casting and follow-up. You know you're going to do a secondary procedure. Be prepared to do it, and do it when you see a certain amount of remodeling that hasn't occurred. In this situation, you're going to treat the deformity of the acetabulum. And again, with the Pemberton, as Dr. Burke showed us, reduces this and treats this very nicely. So what about my results or my technique as far as outcome giving correct patient selection? What's my ability to maintain reduction and keep my AVN rate low? 18% by Eastwood in 2016 has been published, Turgison 14%, I'm at about 17%, and that's over several decades of practice. My AVN has been very, very low, even for type 1. My follow-up is not quite as long as Turgison's. I do plan to do secondary procedures, follow the patients, you have to do it. That is a secondary procedure. So the long-standing algorithm for me for the 4 to 24 months child, I have been and continue to be very pro for closed reduction of DDH. And again, thank you, Woody, for having the chance to participate.
Thanks, Perry. It's always great to hear you talk, and the wisdom in your words is always valuable, and I think that we've all learned from you. So thanks for that. We will move on to try and stay on time. I'd like to thank Suzanne Devos Jacobs, who just came out of the operating room there in the Netherlands, and she has joined us and is going to tell us now how you evaluate this. Both of you, Perry and Oliver, talked about arthrograms and the value of them, but how do you evaluate the quality of a reduction? And Suzanne's going to tell us how she does this.
Thank you, Pablo, for the introduction, and thanks a lot for the invitation. Well, I am going to talk about the evaluation of the quality of the closed reduction. So first of all, I have nothing to disclose, but my slides are not working properly. So yeah, there we are. So imaging in DDH can have the purpose of classification of your DDH, evaluation of the treatment that you're giving or that you're planning, and also follow-up during growth is done with imaging. But today I will talk about the evaluation of treatment. So when you want to evaluate your closed reduction, you can do this with the arthrogram, but the only place where you can perform the arthrogram is directly in the OR. So it's just not something that you can use for the rest of your follow-up. So of course you can use your radiograph. This is the radiograph of the patient that we did the closed reduction of both hips. And because of the asymmetrical aspect of the two hips, where you see that the teardrop metaphyseal distance is larger at the right hip than at the left hip, we also performed a CAT scan to make sure that these hips were both correctly reduced. And then and on the CAT scan, you see that both hips are actually not in the correct position. But if we have to use a CAT scan for every kid that we're in doubt or that we have did the closed reduction, then we need quite a lot of radiation. So that's why in our hospital we prefer to use the ultrasound. So we use the Anterior Inguinal Ultrasound to assess the closed reduction. And I'm going to tell you what the technique is of the Trans-Inguinal Anterior Ultrasound that we use. So the kid is in the frog lateral position, and the ultrasound approaches the hip from anteriorly. So due to that position of your ultrasound, you can evaluate the depth of the femoral head and neck in relation to the acetabulum, because we all know that the position that the hip redislocates is always posteriorly and up, so cranially. And because you do the ultrasound from anteriorly, you can assess the depth of your hip in or your acetabulum in relation to your femoral head. So here's a schematic drawing of how the anterior ultrasound is done. So you see the drawing of a kid in the frog lateral position. You see here the symphysis of the pubic bone, which is one of your landmarks. Here you see your acetabulum, and your femoral head is there, and your ultrasound probe approaches the hip from the anterior side. So these are the most important landmarks for your trans-inguinal technique. This is the image that you get on the left-hand side. You see the image that you get on your ultrasound machine, and on the right-hand side there's a schematic drawing of what you see on this image. So here you see your superior ramus of your pubic bone, which follows into your acetabulum, and you see it on the drawing on the ultrasound at this point. And then here you see your femoral neck, your metaphysis, and that this is the position where you can see that on your ultrasound. And what you want to see on your ultrasound machine is that these both structures are in the same plane. So in this particular ultrasound, you can also see the cartilaginous structure of your femoral head, but that's not always very clear. So that's not the landmark that you're looking for. You want to see that your superior ramus of your pubic bone and your metaphysis of your femoral neck are in the same plane. So that's what this line is showing you. And here is an example of a dislocated hip with your anterior ultrasound. So here you also see your superior ramus of your pubic bone, and there you see your metaphysis of your femoral neck, and you see that this is not in the same plane. So your metaphysis is much deeper, so it's posterior in relation to your superior ramus of your pubic bone. So in practical use, it's like this. You first, with your ultrasound, you search for the pubic symphysis. So you try to find your pubic symphysis. Then you follow your pubic bone all the way to the lateral side, where you find the edge of your acetabulum and the edge of your bony rim. And there you have found your hip joint. So this is how we use it in the OR. And one of the good things of your ultrasound is that it's a dynamic examination. So you can see what happens in the hip joint while moving the hip. So this is how we use it in the OR. We dislocate and reposition the hip during the ultrasound so that we can see what exactly happens in the hip joint with the movement, and what amount of abduction or adduction makes the hip stable, and how much flexion or rotation that you need to have the most stable position of your hip. So this is the technique, how it is done on the ultrasound machine. Here you see your pubic symphysis, and then you follow your pubic symphysis all the way to the lateral side. I hope it is that it's shown well, that the video works properly. But here you go all the way to the lateral side until you see the edge, the bony roof of your acetabulum. Let me see, it stopped. Yeah, so when you go all the way to the lateral side, this is the image that you get on your ultrasound machine. And in this image, you see On the left-hand side, your acetabulum, so your ramus superior of your pubic bone. Why is it not working yet? And on the right-hand side, you see the metaphysis of your femoral neck. And in this image, it's all in the same plane. But here you see what happens if you dislocate the hip and you relocate it again. So that's why it's very useful to have the dynamic imaging during your ultrasound. So here again, you have the dislocation and the repositioning of your hip. The Trans-Inguinal Ultrasound in our hospital is used for quite some purposes. So we use it to confirm the reduction during Pavlik treatment. So if we're in doubt if the hip is correctly reduced during the Pavlik treatment, we can use this technique. We also confirm the reduction in the OR, so during the OR, after the closed reduction, both before applying the spica cast as in the spica cast, and we also use it for follow-up after closed reduction. But the downside is that when you've done a tenotomy, then you can't use the ultrasound for the duration of 1 week because of the gas, the air in the soft tissues that blocks your view with the ultrasound. So if you've done a tenotomy, then you will need to use the radiograph, the CAT scan or the MRI scan. But in all other cases during follow-up, you can use it. You can use the Trans-Inguinal Ultrasound, and it only takes approximately 1 week for the air and the gas in the soft tissue to resolve. So after 1 week, you can use it again. If you want to start using it, then there are some things that you have to take in account, because the radiologist needs enough space in your spica cast to put in his ultrasound probe. So what we do when we make the spica cast is that we put a little bit of cotton wool extra in the groin area, so that the radiologists have enough space to slide underneath the ultrasound probe. And we use this probe, so the hockey stick shaped probe, so it can slide underneath the spica cast quite easily. Also, when your radiologists use the Trans-Inguinal Ultrasound during the spica treatment, it obviously isn't a dynamic examination, because the kids are immobilized in the spica cast. So you only get one image, and this is the image that we get from our radiologists, where you see the superior ramus of your pubic bone. On the left-hand side, you see your femoral metaphysis on the right-hand side, and this is all in the same correct plane. So this is exactly the image that you want to see for a reduced hip. So in conclusion, the Trans-Inguinal Ultrasound is a reliable method for assessing the hip reduction. It is safe to use without having to use any radiation, and there's no need for radiographs during treatment of the hip dislocation in the first year of life, with exception of the tenotomy. So after the tenotomy for 1 week, you will need to use your radiographs or CAT scan or MRI scan. Thank you very much for this opportunity. And if there are any questions, please feel free to send me an email or ask them after this session. Thank you.
Thanks, Susanna. That was outstanding as well. We do have some questions, but I would like to get to the last talk in this block and then keep all of you on for a few minutes for some questions. We've seen how some of this that we've been discussing is very user dependent and slightly nuanced. So I've asked Simon Thomas to tell us a little bit about his experience with medial open reduction and how easy it is to learn and to teach to do this.
Thank you very much, Pablo. So it's a great honor to be invited back again this year for this meeting. So I do think I have a particular aptitude to give this particular talk. I've been a consultant or an attending in independent practice now for the best part of 15 years. And I think I've seen enough talented young surgeons come through now to know that my own surgical skills reside squarely in the below average sector. And I think that's probably partly explains why I struggled rather as a fellow and a young consultant with the medial approach. I found it difficult for a number of reasons. I think it's stressful because it involves operating around those critically important medial circumflex vessels at the bottom of an increasingly deep and dark hole. And different people describe different ways of getting to the hip from a medial approach. Once you get there, different people say different things about what you can do. Whether you should just restrict yourself to a psoas tenotomy, whether it's safe to open the capsule, and if you do, whether you should go ahead and do a ligamentum teres tenodesis to aid with reducing that all-important hip abduction angle in cast. So it's difficult, but I have persisted nonetheless because of the prize potentially of getting direct access to all those blocks to reduction through a small, very cosmetic groin incision done as a day case procedure with little or no blood loss. So whilst on fellowship in Toronto, I made probably one of my greatest leaps forward in terms of understanding the anatomy. When I went to the Toronto Science Centre, Gunther von Hagen was showing his plastinated bodies there. I went there with my young family, and I must say I rather irritated them because I spent quite a long time gazing at the groin prosections. And that enabled me better to understand the three-dimensional anatomy of the groin. And so if we look at that, the approach with the red arrow here that takes us directly over pectineus does take us directly down onto the hip joint, but that scares me a little because we're then retracting directly against the neurovascular bundle. So for those of a more swashbuckling nature, that's probably fine. For me, I'm more comfortable going between pectineus and adductor brevis. So there's at least one muscle between me and that all-important neurovascular bundle. But that only works if you're aware that the hip joint itself is then more medial and superior. And when you're taking your residents through this approach, you must always be retracting in that direction. Now, as luck would have it, nature kindly positioned the anterior division of the obturator nerve very conveniently in the interval between adductor brevis and pectineus. So it sits there almost like a south cardinal mark, directing us in the direction of the lesser trochanter for the psoas release. And if I may just push that analogy possibly a little bit too far, on a foggy day, if you're struggling to see those nerve fibers, which will often have split into separate smaller fibers by the time they've made their way through the interval, if you incise the film-like fascia that sits over pectineus and then push that away with a pledges or a sponge, then matters will become clearer. So another tip from me would be that in order to get properly into the second layer, where we'll find pectineus and adductor brevis, you need to take the full thickness of adductor longus. Now, the tendon of adductor longus is relatively short, so if you come as medially as possible with your incision of adductor longus, you're most likely to get the full thickness of it. When it comes then to finding the lesser trochanter for the psoas release at the end of the interval, you'll feel it before you see it, and that can be aided with the hip flexed and abducted by rolling the femur underneath your thumb and feeling it. There's a wodge of fatty tissue that sits on top of the psoas tendon, which prevents you from initially being able to see it. So those are my tips for people taking it on, which unfortunately only leaves me a few minutes to talk about the indications, which I think are probably the most important part. So there should be a polling question coming up now. As that works, the polling question really is to ask you all how many people are still using the medial approach, whether I'm one of the last people standing in that regard. And for those that do you just use it for a psoas release and avoid the capsule and the vessels, or do you proceed to do capsulotomy as well as psoas release? I'll give you a few minutes just to do that. I don't know whether that polling question's coming up for you. I must say I can't see it on my screen. So
I can share the results with you, Simon, if you want to. Most people are responding. About 50% avoid using the medial approach. A quarter use the medial approach, but only for the psoas release. And another quarter of the people who have responded use it for capsulotomy as well.
So that's interesting. Thank you, Pablo. So I'll tell you what I use it for. We have looked at our results. So when I took up consultant practice, I prospectively kept a record of my medial open approaches, and I compared them with a colleague who was waiting for the appearance of the ossific nucleus and then doing a delayed anterolateral approach. And the results are comparable in terms of proximal femoral growth disturbance, so long as you avoid the golden rule that you must not abduct the hips in the medial open approach group in the hip spike of more than 60 degrees. That's a surefire method after a medial open approach for femoral head osteonecrosis, proximal femoral growth disturbance. I agree with Harry Kim and others who found that you seem to get a better quality longer term result with a lower rate of secondary surgery after the age of 12 months if you do an anterior open approach and capsulorrhaphy, and so that's what I do. I reserve a medial open approach for children up to the age of 12 months. After that, I would do an anterior open approach. The second rule for me is I very much agree with the findings of Dr. Wedge and Dr. Gardner that the vast majority of children that fail closed reduction will then reduce with a psoas tenotomy. That seems to be the key step in about 90%. And when we've looked again at our series, we found that the proximal femoral growth disturbance rate after a closed reduction and then medial approach for psoas tenotomy is the same as for closed reduction alone. That rate then almost doubles if you do a capsulotomy. So if you possibly can avoid doing a capsulotomy, which I think you can in the vast majority, just do the psoas tenotomy. And so it's interesting to see that half of those people in the group that are still using the medial approach would mostly confine it to a psoas tenotomy. So that's my second rule. And then my third rule is to follow these children very closely for residual dysplasia. There is a marginally higher rate when we compared our medial open approach with the anterior open approach in capsulorrhaphy. There is a marginally higher rate of secondary surgery required for these children. And I very much agree with one of the earlier speakers who said that if you don't pick up the relatively high rate of secondary type 2 Avian, type 2 proximal femoral growth disturbance, if you let them get to subluxation, then the outcome is uniformly poor. So watch them closely and intervene early. Thank you very much.
Thanks so much, Simon. So we've had a very wide-ranging group of talks, and we are due for a break, which I would like to give people a chance to, again, stretch and breathe. Quick question just for, there's been plenty of questions in the Q&A, and I appreciate all the audience sending these in. Just if everyone would like to take a break, we will reconvene and start again in 2 minutes to stay on time at 10:20. But over the next 2 minutes, I'd like to have 2 questions answered very quickly. First is for Salil, if you're still on. Could you tell us a little bit about femoral nerve palsy, lack of extension in the knee, your experience with this? Is the tube engine or a von Rosen perhaps a better device when this happens?
Yeah, thanks. I think that is an interesting question. I think most studies have found it to be due to excessive hip flexion, but I think there is a component of what's happening at the knee. And if you're using a brace that's controlling, the foot and holding the knee in a certain amount of flexion as well. I think the tube engine results that have been presented do show a lower incidence of femoral nerve palsy. We haven't had much experience with the tube engine, but I know Zoomin is on the panel, and one of the articles is from him, so it'd be interesting to hear his perspective as well. Also, the counterpoint of just taking the kid out of the brace and stopping the hip flexion allows the nerve to recover. So I think although it does change our management of these infants, in the grand scheme, fortunately, there isn't a big residual from that nerve injury.
Thanks. Yes, we will hear from Zoomin a little bit later on. We do still have 1 minute. I have a question for maybe Perry and Suzanne, though. So you mentioned you do a closed reduction and then you evaluate this, and if it isn't adequate, you'll try again. How many attempts are you willing to undergo under one anesthetic event before you pull the trigger and switch to doing something different? Maybe Perry, can we start with you? 2?
Probably 2. If I'm controlling all the details, I'm holding the legs. 2 times is it.
Suzanne, would you agree with that?
Yes, I totally agree. Because often in the first attempt, then when you see the radiograph or the ultrasound to check, then you're like, oh, well, it's a little poorly flexed, or it's too much external rotation. So then you optimize and then you try again. But I won't do more than 2 attempts.
All right, fantastic. Well, to stay on time, I do appreciate everyone joining on time. And I'm afraid we will have to skip the break if everyone wants to stretch for a few seconds, but we will try to stay on time because we do have all these different time zones. And it's my pleasure to be able to introduce Alex Arvold, who is over in Southampton in the south of England, as we begin to talk a little bit more about the later treatment. And he's going to tell us about the Southampton experience doing open reduction and acetabuloplasty, which is another subject which is somewhat controversial. So Alex, the floor is yours.
Wonderful. Thank you so much. Thank you so much, Pablo. So good day. The acetabuloplasty is a simple procedure designed to stimulate the growth of a dysplastic acetabulum, and it is performed alongside an open reduction. And it takes less time to perform than it will for me to give this talk, if the slides go forward. The procedure was developed by my predecessor in Southampton, Nick Clark, who many of you may know. And it was actually based on a acetabuloplasty described in Beijing in the 1980s. Our technique has been published, but this was only a 2-year follow-up. But we have now been performing this at Southampton for 12 years. It's been taken on by a number of other institutions, including here at NYU. So I can now describe the technique, and I can report on our 12-year follow-up, which is on the first 100 cases, with the minimum follow-up being out to 4 years. All of these children were aged between 1 and 2.5 years old at the time of surgery, and most were IHDI, i.e. high dislocations. So first, the open reduction is done as a standard, and the capsulorrhaphy as well. Then the idea is to get this little calcium sulfate pellet into the lateral aspect of the acetabulum. And all you need is this mini osteotome set, with the osteotomes ranging from between 2 and 8 millimeters in width, giving this final post-operative image. So here is an intraoperative photograph of a right hip. So the baby's head is across to the left, and the right hip is up flexed, reduced, and the capsulorrhaphy performed. You can see the ileum, the apophysis split, and the 2 osteotomes in. So the larger osteotome, the 8 millimeter one, is placed in the mid-axial line, just on the lateral aspect of the acetabulum, and you can see the entry point here. And it is advanced about halfway across the acetabulum, which is usually about 1 centimeter, as you can see here. And then I place thumb on the lateral aspects of the ileum. I place a second osteotome anterior, directly parallel, and directly anterior. And then with the 2 osteotomes, just move them slightly caudally to open the wedge. And you can see the subtle difference here of the osteotome position and the wedge opened. So I will then take out the anterior osteotome and the little calcium sulfate pellet, which measures 3 millimeters in height, and place that into the opened wedge. Now, by holding the wedge open with the posterior osteotome still there. And then this is just tapped into place and is very stable. You see, tap, 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 in it goes. And remove the posterior osteotome. Sorry, the slide's taking a little while for the photos to move through. Remove the posterior osteotome. You can see the little calcium sulfate pellet, and it gives this post-operative X-ray view, which you can see is a far from fully corrected acetabulum. So as an example, here's a girl with bilateral high dislocations, and she had sequential hip open reduction, capsulorrhaphy, acetabuloplasties from 1 year of age, staged about 4 months apart. And this is the first postoperative X-ray in clinic, which is about 8 months following the left hip and 4 months following the right. And you can see the acetabulum is still clearly dysplastic, but you can see there's evidence of where we've been with the osteotomy and evidence of growth. And the left side is a little bit ahead of the right because it was performed 4 months earlier. And then by about a year, the growth is really firing up and the acetabulums are coming over. And then you see the acetabuli continue to develop out at 3 years postoperatively, and at 5 years postoperatively, and at 7 years postoperatively. And this girl is now 8 years old, charging around normally and playing all sports. So of the 100 hips here from minimum 4 years, so 4 to 12 year follow-up, 94 of these have a severing 1 or 2 a good or excellent outcome, which speaks volumes for the center edge angle of these hips. 2 of the 100 hips have come to later pelvic osteotomy. One of these was a shelf for a salvage procedure for one of the less good outcomes, the higher severing numbers. And only one was for a isolated residual dysplasia, and she had a pelvic osteotomy. So if we look at this graph here of the normalization of the acetabular indices, so the mean starting acetabular index was 40 degrees. And at the first postoperative X-ray in clinic, it's a little bit corrected. It's about 30 degrees. There is partial correction just by opening the wedge, but still clearly dysplastic and far from the finished product. The red line is the contralateral normal hip. And you can see after about 5 years follow-up, the acetabular indices become practically indistinguishable. And the mean difference is 3 degrees at that point. Now, you might say that this is the natural history after getting a hip reduced. But we know from this meta-analysis from Oxford that if you do nothing to the acetabulum after a hip open reduction, then 60% will have residual acetabular dysplasia and come to pelvic osteotomy. And that number can be as high as 90% after closed reduction. So clearly this acetabuloplasty is doing something. So in summary, this after you have sweated your way through a hip open reduction, this procedure is simple and quick. It is less invasive than a formal pelvic osteotomy. And as you've seen, it is at least as effective. So after now being a 12-year follow-up, we can confidently recommend this simple technique to be performed routinely alongside hip open reduction. And we've come to term this an open reduction capsulorrhaphy and acetabuloplasty, or an ORCA procedure. And thanks to my surgical colleagues and the medical students who have done the lion's share of the data collation for this. Thank you.
Thanks, Alex. And I like the acronym ORCA. Brings up images of the Pacific Northwest where Kishore was supposed to be, but he's apparently on the other side. So our next talk is going to come from one of the most fascinating minds in pediatric orthopedic surgery, a man who has traveled the world. And he's going to tell us a little bit about developing these techniques in different settings, in resource-challenged environments, because we've heard a lot about these procedures, and unfortunately, not everyone is as talented as Simon Thomas or Alex Arvold or Perry Schoenecker. So it's my absolute pleasure to have Rick Gardner joining us to tell us how to deal with late presenting dislocations in resource-challenged environments.
Lovely, thank you. Pavlik, thank you so much, and thank you for the opportunity and pleasure to join you all today. So I'm talking from Zimbabwe, but I've spent the last 7 years in Ethiopia, where these case discussions are from. I'll just see if I can move these slides on. Thank you. So managing late presenting dislocations is a challenge for us all. And in many low and middle income countries, the etiology can be unclear. Children present with a limp, and the X-ray confirms a hip dislocation, but in some, the cause of dislocation may be an untreated septic hip dislocation from infancy. And in this child, I'll outline our approach to managing the late presenting dislocation due to both DDH and sepsis. So in Ethiopia, DDH is remarkably common, especially in females, likely due to an underlying predisposition towards ligamentous laxity. And the majority of children presents over 2 years of age. Some surgeons offer open reduction in 10-year-olds, but in our environment, with the huge distances families travel to access care, surgery does need to offer a reliable outcome. And the acetabular deficiency in children over the age of 8 years means that achieving a safe, stable, and congruent hip becomes less certain. So we tend to use 8 years as our age limit. Now, we've heard and we'll hear more insight into the anterior approach for open reduction with pelvic osteotomy. And I combine this with either a Salter or a Dega acetabuloplasty. Femoral shortening is required in our setting for the majority of children over 2 years of age. And I find in the older child, the decision to shorten the femur is easy because the hip cannot be reduced without it. But in a child, say 2 years or older, a femoral osteotomy is often advisable if there's marked femoral anteversion that causes anterior instability when the hip is brought into extension, such as in this case, or if there's excessive tension whereby an additional pelvic osteotomy over the top will cause too much tension and risk future AVN or growth disturbance to the developing femoral head. Now, in this 3-year-old, a Salter osteotomy was used with a 1.5 centimeter femoral shortening, and it's advisable to minimize any, next slide, sorry. I just want to move on to slide 5. There we are. Yeah, so in this 3-year-old, a Salter osteotomy is used with a 1.5 centimeter femoral shortening. And when you're combining the femoral osteotomy with the Salter, it's advisable to minimize the derotation through the femoral osteotomy to avoid the risk of posterior instability. The acetabular deficiency in children over 8 years of age means the safe, stable, and congruent hip does become less certain. And in some children, 1 or 2 threaded extra-articular wires can be helpful if the hip has a tendency to decenter after the femoral and pelvic osteotomy. This is only really often needed in the much older child, but they're inserted prior to the capsulorrhaphy and closure of the lateral incision, passing through the cartilaginous greater trochanteric apophysis into the lateral ilium, engaging that medial crest, with direct visualization of the congruency of the hip through the anterior incision. And they can be removed at 6 weeks at the first spica change. For those children presenting over 9 years of age, I don't offer open reduction, and I try to minimize the leg length discrepancy through a contralateral epiphysiodesis when growth allows. But as we know, in some children, when it's untreated, a pseudoacetabulum can form with the lateral ilium. And over time, degeneration can occur, leading to severe pain and disability. In such cases, the options, of course, include non-operative management and arthrodesis, hip replacement, or a pelvic support osteotomy. Now, performing a total hip replacement in our setup in such a case is problematic due to the small size of the implants needed and the need for revision when a child becomes a young adult. And in a very symptomatic child where walking is severely limited due to pain, we perform a pelvic support osteotomy 2 weeks after a girdle stone via the anterior approach, followed by the skeletal traction in this intervening period between the girdle stone and the pelvic support osteotomy. And I appreciate in many of the situations you're coming from that a total hip replacement would be the option of choice. But we use a standard lateral approach for the pelvic support osteotomy. We use a pre-bend 4.5 millimeter TC plate at 55 degrees, and we provisionally apply it proximally and then remove it after rotation is marked with proximal and distal K-wise. The cuts made parallel at the level of the ischium, and when the hip is adducted to 55 degrees, and then the plate is reapplied proximally. A small laterally based triangle is removed to achieve congruency, and we apply a 3.5 millimeter anterior recon plate for additional rotational stability. And the position removes the painful articulation, it retensions the abductors, and creates a mobile and pain-free articulation. And this is the same patient 1 year after surgery with a negative Trendelenburg sign. The untreated missed infantile septic hip dislocation can masquerade as DDH, and management is a major challenge. And we routinely ask for a history of sepsis of unknown origin as an infant associated with hip pain at the time, maybe during diaper change. And the X-ray features of the untreated septic hip dislocation typically shows a more lateral ossific nucleus and a medial metaphyseal beak. And to help decide whether an open reduction should be considered in the neglected case, we now wait 6 to 12 months to see if the ossific nucleus grows on serial radiographs. If it does, I think that the hip in is probably better than the hip out. We offer an open reduction with femoral and pelvic osteotomies as needed. The tissue planes are, of course, very adherent, with the acetabulum obliterated by scar needing careful resection whilst preserving the articular cartilage. And there's usually marked flattening of the head medially. In the presence of severe and complete AVN, I personally don't go for a trochanteric arthroplasties. I'm concerned about the long-term outcomes regarding joint stiffness and early degeneration. I think they may be worse than the non-operatively managed hip. But by way of example, these X-rays and pictures pre-op and intra-op, the child was mistakenly thought to have DDH. And you can note the relatively symmetrical acetabular index on both sides and the teardrop, suggesting this hip was probably once congruent, as well as the small laterally positioned ossific nucleus and low dislocation. And all are suggestive of a possible history of sepsis as an infant. And of course, the intraoperative X-ray picture there, you can see showing a very saddle-shaped concave femoral head with the adherent tissue planes and obliterated acetabulum that we found. And the mother later gave a history of unknown sepsis and hip irritability when the child was a few months of age. So I'd like to show two examples. I'll pass this one here. This was a non-optimally managed child showing a good result can be achieved in complete AVN, which I think is why decision-making for these old septic hips is so important. But I'd like to show just quickly two examples where open reduction of femoral pelvic osteotomies were offered for children following an untreated septic hip dislocation. And you can see in this one, the eccentric ossific nucleus and a medial metaphyseal spur. And the child initially presented at 2 years and 10 months of age with clear development of the ossific nucleus after 1 year. So we offered an open reduction with femoral shortening and a Dega, and a stable reduction was achieved with development of normal gait and a much improved hip motion. And the last X-ray 3 years post-op. Now, of course, there's a significant growth disturbance, but the hip is congruent. The coxa breva will likely occur with growth, which can be managed with a Morsha or Wagner later on in childhood. But we feel this is better than a non-optimally managed hip. And then the second case of missed infantile hip sepsis, again with an eccentric ossific nucleus with an ossification defect and a medial metaphyseal spur. And the ossific nucleus, after open reduction and femoral pelvic osteotomies, improving, and the ossification center filling or ossification defect filling in with a more normalized hip anatomy. So in conclusion, we always ask for a possible history of missed hip sepsis. And if the underlying cause is sepsis, we wait for the growth of the ossific nucleus before deciding on open reduction. In the adolescent with severe hip pain following DDH, I think a pelvic osteotomy is an effective surgical option. And in the older child, if you're struggling with getting a consent or maintaining reduction in the OR, then a threaded wire through the GT and ilium for 6 weeks can be an effective solution temporarily. Thank you very much for this opportunity and to be a part of this.
Fantastic. Thanks, Rick. So that's great. And we're almost back on time. And I'm going to throw it up to another Simon, who is going to tell us about one of the most tried and tested methods for treating this. He is currently at Sick Kids, where the original cohort that I presented a while ago on, and Simon Thomas actually published. But Simon Kelly is going to tell us about anterior open reduction and pelvic osteotomy.
Okay, great. So thanks very much, Pablo, for inviting me to this really fabulous, comprehensive review of hip dysplasia. So again, talking about the anterior open reduction and Salter osteotomy. Okay, so we'll run through the indications, how I prepare the patient for surgery, show some videos of the surgery itself, and then a brief word on post-operative management. So the indications then are children over the age of 18 months with a developmentally dislocated hip. I'll typically add a femoral shortening after 36 months of age, but I've certainly also added it in younger children where necessary for an irreducible hip. The upper age limit for me is typically don't do this over the age of 9 for unilateral dislocation, or typically not over the age of 6 for bilateral cases. So I always wear a headlamp for this procedure, use a radiolucent operating table, use a 3D image intensifier, and always have a cast technician to improve the qualities of our spica casting. So the child is under general anesthesia. We put in antibiotics on induction. It's important to put the bolster under the hemithorax rather than the buttocks so it doesn't get in the way of our approach. The leg is draped free, and then we drape from the costal margin anteriorly to posteriorly in the midline, so nice wide draping. So I'm going to show some videos, but in brief, we're going to do a percutaneous adductor tenotomy, oblique bikini line incision, because we're going to be using the Smith-Peterson interval between sartorius and TFL, protect the lateral femoral cutaneous nerve, and then clear that ridge between the anterior superior and anterior iliac spine. So here's where I'm hoping the video is going to work. Nice. Okay, so anterior superior iliac spine, a finger breadth below that is the interval. That's where we're going to center our incision. I also draw my incision for the femoral osteotomy should I need it later in the procedure. Okay, I'm just going to move that on. Okay. Here we go. So making the skin incision. We'll then cut through the fat with cautery, roll that fat up to the iliac crest, and then feather the external obliques just enough so you can see the top of the crest there. Then find the Smith-Peterson interval directly distal to the anterior superior iliac spine, catch the bleeder, and then split the apophysis with a 10 blade from the midpoint of the ilium down to the superior iliac spine, and then down to the rectus insertion at the inferior iliac spine. So now is the point where we split the apophysis. There we go. So I use a spade elevator to do this. Pop the apophysis and be careful to do a clean subperiosteal dissection down to the sciatic notch. Note the direction. You don't want to go posteriorly because that's where the SI joint is. Then pack the interval with a sponge, which is great for hemostasis and also freeing up those soft tissues. So next then we're down to rectus. So it's important to tag, cut and retract the rectus femoris. And I'll show you that step on video now. Okay, so use a Mayo, find the rectus, pass those Mayos from medial to lateral. Just clear rectus from the capsule before you tag it with a 1 vicryl, and then cut the rectus, leaving around about sort of 5 to 8 millimeters of rectus attached to the inferior spine for reattachment later in the procedure. So now we're down to the capsule. Okay, so the plan now is we need a wide exposure of the capsule. So we need to go right across anteriorly. So we need to separate psoas from the front of the capsule. And that's really important to do that before actually releasing psoas over the brim. It makes the capsulotomy a lot easier and a lot safer. Then we need to clear the lateral capsule by getting under the abductors, between the abductors and the capsule, and then releasing the abductocapsular interval. Okay, so I tend to use a spade and a sponge to really spend time clearing the psoas off the front of the capsule. Sometimes this can take quite a long time in the older child where it's really stuck down, but very important to be able to pass your finger right under the psoas there. When it's completely free, hook psoas over the brim, leaving the muscle behind, just taking the tendinous portion. Obviously check that it is indeed psoas, so muscle going into the tendon itself. It will move as appropriate when you move the leg. Check it with cautery and then just release the tendinous portion. And you'll find when you put your finger back across that it's freed up and there's that release of the tightness across the anterior hip. Okay. So now we're going to clear the lateral capsule. So again, use a spade over the top of the capsule, beneath the abductors, just over the zenith of the head, and then release between the subperiosteal space and the abductocapsular interval with Mayos. Then get ready to make the capsulotomy, about 8 to 10 millimeters distal to the acetabular rim, so you don't injure the labrum. Use a little 15 blade to make the incision. Capsule's always a bit thicker than you think it is. Then use a McDonald to really just probe the acetabulum and get a sense of the line of the anterior acetabular rim, which then guides my capsulotomy with the Mayos. And again, this is under direct vision. You have a nice clear view all the way across to the medial acetabulum, and then turn the scissors and create the lateral aspect of the horizontal limb of the T capsulotomy, again, just over the zenith of the femoral head there. Ligamentum teres then needs to come out, make sure it's completely cleared from the head and from the base of the acetabulum, and release the transverse acetabular ligament. So at this stage, the hip should actually reduce very nicely. If it doesn't, you may need to add a femoral osteotomy. If the hip does reduce nicely, concentrically, that's the stage at which I then perform the T limb of the capsulotomy, around from the insertion of rectus down along the line of the femoral neck, but no need to go all the way down to bone. And you'll see that when you reduce the hip now, that medial limb of the capsulorrhaphy actually wants to come right across the front of the hip. And it's really demonstrating how the T capsulotomy turns really into a V, which will tie with capsulorrhaphy sutures later. Okay, so as I said, I put this slide up just to remind myself to say that this is the point where I decide on whether I'm going to add a femoral osteotomy or not. If the hip's not reducing, then it probably needs shortening. But if it does reduce, I also assess version at this point. I'll accept, up to 40, 50 degrees of version, but sometimes you can have really extreme amounts of femoral anteversion, in which case I'll perform a derotation osteotomy at this stage. Although, to be fair, under the age of 3, I probably only need to add that in 10-15% of the time. So it's not so common. But that will be the decision point then before I proceed further. So we then put in the sutures for the capsulorrhaphy, as is described in Dr. Salter's article. And we put those sutures in. I use 4 1-ethibond sutures. Okay. And if I'm right-handed on a right hip, go from the femoral side to the acetabular side, 4 sutures in from the tip of the apex there, right across the front of the acetabulum, keeping all sutures medial to the insertion of the rectus. So you can see all sutures are in place, but not tied yet. We do the pelvic osteotomy before we tie the sutures. Okay, so as I said, osteotomy next. When I do a Salter osteotomy, we use these Rang retractors. They're fabulous for giving us exposure down to the sciatic notch. We'll pass a jiggly saw and then cut from the sciatic notch up to just proximal to the rectus insertion. Okay, so here we are going in with the Rang retractors. Actually, not like this video. I typically put the lateral one in first and then the medial one on top of it, because we pass the jiggly saw. It's easier to pass from medial through to lateral, as you can see there. Once the jiggly's through, then cut the ileum perpendicular to the ileum, not perpendicular to the patient. Really important to keep it square. And then we'll pass that jiggly saw, cut out through just above the anterior inferior iliac spine. Just like that. And we're done. Try not to let the jiggly go on the floor at that point. It has a habit of jumping out. Okay, so now we're going to cut bone graft. We're going to take a piece of bone graft from, again, just where the osteotomy exits up to the midpoint of the ileum, a very consistent triangle of bone. Use an oscillating saw to cut the bone graft, keep hold of it with a cocker for later use. Okay, so then we want to open the osteotomy, rotate the acetabular fragment anterolaterally, insert the graft with a medial bias so the pins do actually go through the graft, keep the posterior aspect of the osteotomy closed. So the wires we use usually 2 or 3, 2.8 or 3.2 threaded Steinmann pins, which pass through the cut portion of the ileum, through the bone graft and posterior to the acetabulum, stopping short of the triradiate cartilage. Here's a picture of that with the graft and pins in. And so here we go. So mobilizing the fragment, really important just to mobilize the distal fragment, but not pulling up on the proximal fragment. Otherwise you'll correct through the SI joint, not the symphysis pubis. Take the graft, pop the graft into the opened osteotomy, keeping it closing at the back. The graft doesn't need to go all the way to the back, or you will open it posteriorly. Then put the 2 threaded Steinmann pins in, put those in on power, and then we'll be checking once they're in that they're in the right place on fluoroscopy. Okay, so take a fluoro shot, And again, just to confirm the quality of the reduction, the fact the osteotomy is not opening at the back, you actually want a little bit of anterior translation at the back to confirm rotation of the acetabular fragment, the pin stopping at the triradiate, the obturator foramen showing a nice little a bit of obliquity compared to the other side, and that we'll be happy with that image. So next we tie the capsulorrhaphy as per the diagram here, converting a T to a V. We are using a double-handed tie for each of those sutures whilst holding the hip in place, and I tie them from medial through to lateral. Once they're all tied, then I cut them at that stage. Okay, so I'm actually going to skip through all of these because I know I'm well over time, but these were really just highlighting the tips and tricks that are really important in terms of managing this operation. So in terms of post-op care, then I put on a single leg hip spiker cast with 20 degrees of flexion, abduction, internal rotation, a belly hole for comfort. Use three-dimensional imaging always. I use an intraoperative 3D fluoroscopy to confirm that the hip is actually centered. I no longer get post-operative 3D imaging. In terms of post-operative care, cast for 6 weeks, non-weight bearing, come to clinic, take the cast off, weight bear at 6 weeks, no supplementary casting, and then follow regularly to ensure continued reduction and development of the acetabulum. Okay. Apologies for going over, but thanks very much for the opportunity to present, and I'll take any questions later. Thank you.
Well, thanks so much to all of you for that. I'm afraid, yes, we are a little bit over, and I would like to be mindful of giving some people some time to stand up and look away from the screen to avoid this Zoom burnout. So we are just a little bit over, and I would like to give people 10 minutes before we reconvene. I'm afraid we will have to cut the Q&A a little bit short, but if the panel is able to stay on, perhaps at the end of the next block, we will try to sum up all of the questions. So we will reconvene at 11 a.m. here on the Eastern time zone, which is in 8 minutes now. Thanks so much to everyone. All right, well, welcome back, everyone. I'd like to thank all of our speakers for staying pretty much on time. We're only a few minutes late, and again, I hope we can catch up because I would like to encourage some more discussion. So we're going to move on to the next block, and we're going to hear from Joachim Horn in Oslo, who is going to give us a perspective on the long-term outcomes and some of the work that one of his senior partners, Professor Dergesen, has presented. Joachim, thanks for joining us from Oslo.
Thank you, Pablo, and thank you again for inviting us to this symposium. We are really honored and pleased. So I shall present our results on the long-term outcome of late-detected DDH. There's agreement that the aim of treatment is to achieve a normal hip joint and to avoid osteoarthritis. And however, there are several points of disagreement. Should traction be used? Should we use open or closed reduction? And the indications and type of procedures at later surgical correction. Long-term follow-up is important because the outcome deteriorates with the length of the follow-up. So the aim of the study was to see the outcome at an age of 58 years of late-detected DDH treated with closed reduction, and which factors predict a satisfactory or less satisfactory outcome in these patients. The material consists of 60 patients, 74 hips, and they were treated between 1958 and 62. And the mean age at diagnosis was 17 months. They were from 6 to 34 months. And the initial treatment included skin traction, followed by closed reduction and hip spiker cast. The aim of traction was to obtain gradual reduction of the hip. The position of the legs was in abduction, slight flexion, and moderate internal flexion and internal rotation. The average time in traction was 33 days, with a range from 16 to 65 days. Here's an example of a gradual reduction by traction. On the left, we see a patient aged 19 months at diagnosis with a dislocated left hip. In the middle, we see the X-ray after 2 weeks of traction, and to the right, after 6 weeks of traction, the hip is reduced, and the spica cast is applied with legs in the same position. And at age 50 years, good femoral head coverage and no signs of osteoarthritis. The age at hip reduction in our patients was 19.6 months. The average time at hip spica cast was actually 9 months, with a range from 6 to 20 months, which is quite a long time, of course. So additional surgery to improve femoral head coverage was necessary in 22 patients and 25 hips at a mean age of 11 years. Proximal femoral osteotomy with varization and derotation was done in 11 hips, and acetabular shelf operation with the Spitze technique in 12 hips. The acetabular shelf operation is a technique where a solid bone graft from the pelvic crest is impacted into a slot just above the acetabular labrum. On the left, you see a picture of a 12-year-old girl with a subluxated right hip. And to the right, you see a 4-year follow-up after Spitzeplastik with a good coverage of the femoral head. In this long-term follow-up, we included 59 patients with a patient age, mean age of 58 years. Patients were evaluated for osteoarthritis by measuring the joint space width. And we looked at the rate of total hip replacement, and we took a modified Harris hip score. The results are combined in clinical radiographic outcome. A good outcome was defined by no osteoarthritis and the Harris hip score more than 80 points, which was found in 39 out of 73 hips, which is 53%. Poor outcome was defined by osteoarthritis or a Harris hip score less than 80 points, which we found in 47%. So this slide shows the predictive factors for the long-term outcome in terms of satisfactory or unsatisfactory outcome. Age at reduction more than 1.5 years was associated with an unsatisfactory outcome. And the same was for the Severin grade 3 and 4 at skull maturity. These patients showed an unsatisfactory outcome. Risk factors was residual dysplasia. We see here a 15-year-old with a dysplastic left hip, and here at age 51 with severe osteoarthritis, and she was operated with a total hip replacement. 24 hips, 32% needed total hip replacement at a mean patient age of 48 years. And the Kaplan-Meier survival analysis showed after 30 years a survival of 100%, and at the age of 58 years a survival of 62%, but the less favorable survival for patients older than 1.5 years at reduction. They showed a survival of only 54% at age 58. So this slide shows a comparison with previous studies. Malwitz and Weinstein. The patients were 1.7 years at diagnosis, treated non-operatively. At age 31, 11% had received total hip replacement. Thomas and colleagues, mean age 2.8 years and treated by open reduction and osteotomy. At age 46, 31% had received total hip replacement. So we see an increasing frequency of total hip replacement with age, and in the present study, with an age at diagnosis of 1.5 years and closed reduction at age 58, 32% had received a total hip replacement. So no better outcome after open reduction and sorted pelvic osteotomy than after traction and closed reduction. So the study may allow some conclusions. After a follow-up of more than 50 years, the clinical and radiographic outcome was satisfactory in 53% of the hips. Risk factors for poor outcome were age more than 1.5 years and residual dysplasia or subluxation and AVN. In these risk factors, if these risk factors are avoided, the hip will probably last more than 50 years. Thank you for your attention.
Thanks, Joachim. I think that one of the advantages of these papers, I don't know why it is, but people don't seem to move, and you're able to get these 50-year follow-ups in Norway and Iowa. And I think that this experience you've shared with us is truly invaluable. And I really appreciate you filling in for Professor Terjesen, who was slated to give this talk, and I know that you filled in at a later date. So I'm very grateful to you for doing that.
Thank you, Pablo. You're welcome.
Thanks. Let's move down to France now. Clermont-Ferrand with Federico Canavese, who is going to talk to us a little bit about how he makes decisions when seeing children with acetabular dysplasia.
Thank you very much, Pablo, for the invitation. And there are some news because I just moved to another university. Now I'm living and working in Lille, in northern France, but still France. So the basic goal in the treatment of DDH, as we have been discussing today, is to maintain a concentric reduction as to allow the hip to develop normally. Thanks to several natural history studies, we know that these plastic hips become around 20 years of follow-up, and that subluxation leads to the onset of osteoarthritis. On the other hand, dislocated hips tend to do a little bit better because they don't cause disability before the 5th decade, and there is a variable evidence of knee and back pain, and worse longer-term outcome has been shown, as you can see in this slide, acetabulum. In this upcoming slide, we have a 16-year months old young girl with the left dislocation, and in this case, as you can see, the hip didn't remodel throughout the follow-up period, and by age 5 years, the patient had persistent acetabular dysplasia. So persistent acetabular dysplasia means that the acetabulum is shallow or vertical, and this cannot provide an inadequate coverage in order to contain the femoral head in a well-reduced position. And this abnormal edge contact loading leads to acceleration of arthritis. However, it is not really known what is the frequency of this persistent acetabular dysplasia. If we look at the literature, we have a broad range between 4.9 and 33.8%. And the lowest limit, the lower limit of persistent acetabular dysplasia is probably related to the fact that in this analysis, most hips were stable. But there are several other papers that have identified more or less a 16% risk of persistent acetabular dysplasia. And the only clear factor that has been so far identified and proven to be a risk factor for persistent acetabular dysplasia is graft type 4 hips. Another important point is that even when you have ultrasound normalization of the hip, having a normal hip at the end of the Pavlik Harness, for example, doesn't guarantee the development of the hip in a normal way. And these two works have clearly pointed out that about 16 to 30% of patients had persistent acetabular dysplasia even if at the end of the treatment, the ultrasound were normal. So in patients that have failed initial treatment and have developed persistent acetabular dysplasia, pelvic osteotomy becomes the treatment option. And this strategy needs to be performed taking into account the age and the morphology of the dysplasia in order to ensure the best possible development of the hip and reduce, as I mentioned before, the risk of arthritis. So the pelvic osteotomy has as a main goal to realign the native acetabular, to increase the acetabular coverage of the femoral head, to reduce the abnormal contact factors in order to prevent from early degenerative changes and avoid early hip osteoarthritis and later arthroplasty. However, what is controversial, and this is the first variable that comes into the treatment algorithm, is when to perform the pelvic osteotomies. These are procedures usually reserved to older children. However, the type of osteotomy may change according to the age of the patient. And another important point, and this is the second variable also that has to be taken into the treatment algorithm, is that the acetabulum tend to develop for longer period compared to what was previously thought. Recent publications have shown that the acetabulum, the acetabular index and the center edge angle tend to improve over a period of 8-9 years, so up to age 8-9, if the hip is well located. Here we have this case, a young girl with the left dislocation. She was treated by closed reduction. And as you can see here, the hip and the morphology of the acetabulum developed over time. And by age 11, the hip reached normal configuration. So, and this is the third important issue, what type of pelvic osteotomy you should consider to treat a specific disease. So, the most common procedure are the Pemberton, Dega, and Salter osteotomy that tend to reshape and reorient the acetabulum, particularly the Salter osteotomy. And this procedure should be performed or are better indicated in patients younger than 5 years of age. However, the literature doesn't clarify the age limit guidelines for such a procedure, but is sure that with increasing age, it's more and more difficult to achieve a correct acetabular coverage with a single cut. When the patient grows older, the other option, whether the child has open or closed cartilage, a triradiate cartilage, is performing a triple osteotomy. And this is a powerful reorienting procedure that should be reserved for children usually older than 6 years of age. And then we are dealing with pre-adolescents, adolescents, and young adults. And when considering the adolescent and the young adult population, reorienting procedure and hip-preserving surgery, meaning the periacetabular osteotomy, should be performed. And this is a good procedure because it preserves the posterior column and leave intact the intrapelvic space. So this is the very first part of the algorithm that I try to summarize in this slide. This is the basic. We have open triladial cartilage, patient younger than 5 years of age, patient older than 6 years of age, the choice of your procedure, and then you have older patient, skeletally mature, where you can perform the periacetabular osteotomy. However, the situation may become more complex because into the algorithm at this stage, you have to include the combined procedure that have been recently introduced and the salvage procedure. So when you deal with the patient older than 9 years of age and persistent acetabular dysplasia, the Pember triple procedure, as described by Xuemin Lu, can be performed. But when you deal with adolescents and young adults, you should probably consider salvage procedure such as acetabuloplasty according to Staeli, Spitzi. There are different techniques, or Chiari osteotomy. So among the combined procedure, as I mentioned, the Pember triple is an acetabuloplasty in association with an acetabular redirectional osteotomy. And this technique, together with a femoral shortening, these radiographs belong to Xuemin, can reshape and reorient the acetabulum. However, being a quite powerful technique, it carries the risk of creating some impingement after the surgical correction. The salvage procedure are two categories. One is the Chiari osteotomy, and the second one is the acetabuloplasty. This procedure, in my mind, should be reserved to non-concentric hip. Both can be applied. However, if you have a subluxed hip, the femoral head, you should prefer the Chiari osteotomy. Both techniques requires capsular metaplasia, so your cut or your graft should be placed right on the top of the capsule and provide slightly different correction. The acetabuloplasty can provide you a more anterolateral coverage, whereas the Chiari osteotomy provides you with a true lateral coverage of a subluxated hip. So to conclude, I'm sorry my presentation got longer because there is some slow transition in between slides. I try to summarize all the concepts in this final slide. It is important to take into account when making your decision the age of the patient, the status of the triradiate cartilage, the type of reduction you could achieve with the initial treatment, whether it is concentric or not. And then, according to this parameter, you can select your osteotomy. And also, the choice of osteotomy will depend on the type of action you want to get. More redirectional osteotomy and want to correct more a deficiency anterolaterally or laterally, or if you want to more reshape the abnormal acetabulum. Thank you very much.
Thank you, Fede. That was outstanding. I think all of you have done an amazing job of trying to condensate a huge amount of information into these 7-minute talks. And we've done a very good job with it. So moving on, though, we will continue. And it's my absolute pleasure to be listening to someone I could listen speaking to about hip dysplasia every day, because every time I hear him, I learn something new, and I find his words are just filled with pearls of wisdom and knowledge. So it's my pleasure to introduce Professor Stuart Weinstein from the University of Iowa, who is one of the world's most renowned experts, and especially of the long-term outcomes of closed and open reduction with pelvic osteotomy. Stu, thanks so much for joining us.
Sorry, there we go. My apologies. We'll be talking about closed versus open reduction long-term follow-ups in an older age group, and I have no conflicts of interest. And I think we're all here today because we know that hip dysplasia is such a major problem that we're trying to prevent osteoarthritis in old age. And when we're faced with a youngster with a DDH, not always is the outcome perfect or a normal hip. Sometimes we're left with subluxation or dysplasia. And I think it's important also to emphasize that we're not talking about dysplasia in the absence of DDH. These are only patients who've had DDH. And I'm going to give you a unique comparison in a group of completely dislocated hips that were treated by closed reduction at the University of Iowa over a period 1938 to 1969, comparing those to a group that were treated at the Hospital for Sick Children in Toronto. And I need to give you some historical context about this because the Iowa series was actually begun treatment over 100 years ago by Professor Steindler. Steindler was a very smart individual who used the best evidence of the day to develop a treatment protocol, followed the patients. If patients were doing well, he continued. If they weren't, he reevaluated the evidence and continued to follow his patients. His student, Ponsetti, continued to follow these patients. And then Dr. Ponsetti's student, me, continued to follow those patients to the present day. So just a little bit of background, because we wouldn't necessarily treat these patients the same way in 2021, but Steindler trained in Vienna, and after finishing his training, he worked for Lorenz, who you heard about earlier today. Lorenz developed an allergy to carbolic acid and therefore could not operate and became a bloodless surgeon, and he treated pediatric orthopedic conditions by manipulation. So Steindler was heavily influenced by Lorenz and also Putti and John Ridlin in the United States. And when he came to Iowa in 1913, he practiced Lorenz's bloodless manipulation using traction, which was manually applied, manipulating the hip back into the socket, and plaster cast to maintain the reduction. Now, I think it's important for everyone listening to realize that open reductions were not done in the first half of the last century. It's a fairly recent concept, and this monograph by Severin in the 1930s shows the use of the femoral head to overcome the obstacles to reduction. So the hip was brought in close proximity, and hopefully the femoral head would sink in there and overcome the obstacles of reduction. Open reduction per se didn't become widely used around the world until the 1950s and 1960s, and Bob Salter was certainly one of those pioneers. Now, we had a chance to look at these closed reductions long-term over a 40-year period of time. And these were just treated by closed reduction, no open reductions at all. And what we learned from this over the long term is that you can never accept dysplasia or subluxation. This always goes on to develop osteoarthritis. Now, contemporary treatment of a child 18 months of age or over would generally warrant an open reduction in nominate osteotomy, all of the teachings of Salter. And this more aggressive approach assumes that the acetabulum won't normalize, and hence the risk of this additional surgery is worth it at the time. So these cases were also reported by one of our speakers this morning, Simon Thomas, along with John Wedge and Salter, the long-term results of these patients. And we thought it would be very interesting to compare these two relative contemporary series of closed reductions versus open reduction and nominate osteotomy in children 18 months of age or older, and look at the hazard of total hip arthroplasty over time. So if you look, the closed reduction group was 58 hips who underwent closed reduction compared to 78 hips of a similar age range treated by the open reduction in nominate osteotomy. Both groups were followed for a minimum of 40 years, and observations of survival analysis were terminated at 48 years, since that was the longest follow-up in the Toronto group. You can see the age at reduction was very comparable. the innominate group was just slightly older, but these are all, again, children over 18 months of age. If you look at the survival characteristics, a la our previous talk, you notice that at 40-year follow-up, the survival rates are very comparable. But when you get to 50-year follow-up, you see the marked drop-off both in the closed and the open reduction group. So most hips were surviving fairly well up to 40 years, and then deterioration continues. And interestingly enough, the average hip age for total hip replacement was just under 40 years of age. And you've heard that theme a little bit earlier today as well. And you notice that between 40-year follow-up and 50-year follow-up in both groups, both the closed and the open reduction group, the failure rates doubled in both groups going on to total hip replacement. When you look at the hazard of total hip and model it of the treatment type versus the age of reduction and bilaterality, you find that in unilateral cases, neither the treatment or the age at reduction was a factor in outcome for having a total hip replacement. But in bilateral cases, age and the treatment did have a significant factor on outcome in bilateral cases. And this is graphically represented in these lower left and lower right-hand box. In the bilateral case, in the 18-month-old patient, the closed reduction seemed to fare better, though, again, you can see this stark drop-off between 40 and 50-year follow-up. Whereas in the bilateral cases, at older age group, 36 months of age, the open reduction and innominate osteotomy group had better survival. Now, both groups had complications, as expected in hips treated in those ages, and patients with complications naturally had a higher likelihood of total hip replacement. Now, one thing that wasn't recorded in the Toronto group was the incidence of proximal femoral growth disturbance. And in our closed reduction group, we had a very high incidence of proximal growth disturbance by using the femoral head to overcome the obstacles reduction. And that profoundly influenced our results. There are certain limitations when you do this comparison, small sample size, many of the risk factors and other events are really not available that might have affected outcome. And neither series represents the independent factor of the single approach to the surgery. And both institutions have changed protocols over time. But I think what's very clear is that these treatments, both closed reduction and open reduction and innominate osteotomy, have altered the natural history in a positive way from untreated patients. And in the very older patient, the open reduction and innominate osteotomy did provide for a longer survival. To me, the take-home message of this is that what you learned in the very first lecture is that early detection is critical, that no matter what we do, once we have a late detected case, and no matter how satisfied we are with the technical outcomes of the surgery, that the patient is most likely going to have a total hip replacement. And these hips deteriorate generally around 40 years of age. And then it's a very slow, steady deterioration thereafter. Thank you.
Thanks so much, Stu. Again, that's one of the, I think, the greatest ways of looking at this is truly looking at the long-term view, and you've been extraordinary in showing us this. We're almost back on time. If I could ask you guys just to pull up the next talk, Debbie Eastwood. But while I have the three of you, Joachim, Fede, and Stuart, there is two questions here from the audience. The first is a question actually from Chad Price, who asks, is it accurate to report long-term results of closed management when 25 out of the 60 patients require additional surgery? Shouldn't this really be the long-term results of combined closed reduction and subsequent surgical treatment? So Joachim, I suppose that question is for you.
Yeah, I could agree on this. I think it's as close as we come to report historical results of the closed reduction regime with a slow gradual reduction at that time, a method which we have abandoned and we have changed the protocol. But yeah, I might agree that we might call this the long-term follow-up of closed reduction combined with surgery, which was necessary in a certain number of cases, yes.
All right, thanks. Fantastic. Let's try and keep on time. We have another question from Jose Pablo Munoz in Costa Rica, which perhaps Debbie will touch on this, about when should you consider an osteotomy. His specific question is, how do you use advanced imaging and, for example, using an MRI? But I'm going to hand it over to Debbie Eastwood from Great Ormond Street, who is going to tell us about when should you consider doing an osteotomy.
Thanks, Pablo. So I am so sorry that this is a virtual congress, because New York City is one of my favorite places. And I do have to declare that I do have some conscious biases, and I'll do my best to work around those and not let them interfere with what I'm talking about. This is a very philosophical talk, and there's going to be very little data, but just what I think when I look at a case of acetabular dysplasia. So first off, we've got a polling question. For developmental dysplasia of the hip in this 12-year-old girl who presents to me for the first time, simple question, would you operate? Yes or no? So while you're just thinking about that, what do I see when I look at the X-ray? Well, it's embarrassing that this is her first presentation and I live in a westernized country where I thought we were better at screening. So then if this is bilateral, straightforward DDH, is that right? These hips look a little different from what I would normally call DDH, and therefore I'm looking at some various features. So obviously there is significant dysplasia. Obviously there is a huge break in Shenton's line, and I think the hips have quite valgus femoral necks. So I'm beginning to wonder if this is truly the old-fashioned developmental dysplasia of the hip or something else. So would we operate or not? I've often been told that for bilateral bad cases like this, over the age of 7 or 8 or 6 or whatever the conference decides, you should leave them alone. But I don't think that's right these days. So would you operate, yes or no? Do we have any answers, please? You're muted, Pablo. I can't hear you.
Sorry about that. We do have some responses. So 88% of participants have said they would operate, versus 12% who have said they would not operate.
Right. So, given that you are going to operate, we should always take a really full history. And I didn't quite like the fact that her symptoms were of a limp and a bit of a waddle. And I just didn't like what I was seeing on examination. So we did some tests. And so she is now diagnosed with hereditary sensory motor neuropathy. We did an arthrogram because I do like some dynamic imaging, and we've got some reducible subluxations. So my second question is, assuming you would operate, and we've got bilateral reducible subluxations, do we do left and right on the same day, above and below the hip joint on both sides? Or would you prefer to do them staged as sequential procedures? So whilst you're looking at that question and perhaps answering it, what am I thinking? Well, I'm thinking that she's got a neurological condition. I know that if I immobilize her for too long, then she might weaken and her walking tolerance might be worse and that she might have difficulty rehabbing. And that's what her parents are very concerned about as well. We also know it's been one hell of a year, and she's lost a lot of time off school and is very keen to get back to school as soon as possible. So are these family factors, social, environmental factors, are they important or are they not? And I think they are important. They don't override things, but they're things that I think help me decide when I'm going to pull the trigger. So same day, all 4 bones, or staged? Pablo, what's our answers?
Well, we're getting more and more responses in. It's consistently been 33%. So a third of people would do it on the same day, and 2/3 would do it as staged sequential procedures.
Great, thanks. I'm glad the audience agrees with me. So we are aiming for staged sequential procedures. Sorry, Pablo. So in answering those questions, I've tried to emphasize that to me, history is important, relating to the current symptoms, but also to her current diagnosis, and most particularly to the past treatments, and therefore your understanding or the surgeon's understanding of the pathology that is affecting that hip. So this young girl does have a developmental dysplasia of the hip, but I'm not sure that it's our classic one. It's more influenced by her neurological condition, but that's hypothesis. We know that we have to think about the timing. So my question to my more adult colleagues was, should I wait until the triradiate is closed to do a PAO? Because do you believe that the PAO is significantly better than the triple? Or should I go right ahead and do the triple? And also, I want to know when her last procedures were. Now, in this case, there were no previous procedures. And I also think having the family on board is really important, as do all of you. But I just want to mention that because this is an art and a science of trying to know when to pull the trigger. So when do I do an acetabular osteotomy? I hope when the time is right, judged by when the hip is failing to improve in the way I expect it to radiographically, or in fact worsening clinically and or on X-ray. Because the treatment I am instigating is to alter the natural history and to improve current symptoms, and hopefully both. Or maybe if she's got no symptoms, all I'm doing it for is to alter the natural history. So the indications for your surgical intervention may influence the risks you're prepared to take. And that's going to be an individual basis with you and your parents. So let me start with the hip that you know really well. This is a child who presented to you promptly with her DDH. She had successful early treatment. She's now got some residual dysplasia with or without some subluxation. And there may be that lump sign of the uncovered femoral head in the groin, which I think is quite an important sign. It may be getting progressively worse over time or simply failing to improve. So when do you pull that trigger? So there are some differences between the Americans and the Europeans in terms of what we look for on the X-ray. The acetabular angle is important to both of us, and Shenton's line perhaps a little bit more important in North America than in Europe, but only just a little bit. And what we have to remember is that the bony acetabular index improves markedly over the first 4 years of life in the normal hip, but the the cartilaginous acetabular index stays more or less the same. We do know that after any particular treatment, it takes time for your acetabulum to change. It may not take that long when you're treating a Pavlik harness. And if I do a closed reduction for a DDH, and that's my on-table arthrogram, and I accept that position, then 6 weeks later, I've got a much better cartilaginous acetabular index, but the bony acetabular index has had no time yet to improve. So when do I start feeling that something has to happen? Well, this paper from quite a while ago now would say that at 2 years post-reduction, you could still expect some improvement. But by 4 years, there's going to be no difference between what you've got at 4 years and what you've got at 6 years. So maybe if you've had the child since early age, then if the hip is not improving as you expect it to be, then you should be treating before school age. What about the hip that is new to you? It may be bearing scars of previous treatments or not, as in the case I presented earlier. And these scars may be on the acetabular side, but also on the femoral side. We've looked at that in earlier talks. So the hip that is new to you, these two different hips, what is the prognosis? And is it the same for both patients? And I would like to think that it isn't. So therefore, you've got to think carefully as to which hip deserves which treatment. In answer to the question about what sort of imaging, we can have static, but I do like my dynamic imaging. And up until now, the MRI has not yet been able to give me the dynamic imaging that I would like. So this hip with its dye in the joint outlines a reducible subluxation and shows me that the acetabulum is indeed quite dysplastic. And the femoral neck is perhaps not as bad as we thought earlier. We've got to beware the long leg and the stiff hip. And I would ask you that any time a hip comes to see you, you ask for the history of the treatment and you go back in time, right back to the beginning if you're interested in the pathology, to try and work out whether this was a true dislocated hip or simply a dysplastic and subluxed hip when it started. It may not influence your management just now, but it will add to your learning of how hips behave. And then lastly, there is the hip that has now come under your control. It's had residual dysplasia, multiple previous procedures. The doctor-patient relationship may well be a little fraught, and there may not be much faith maintained in the medical profession, and their expectations of what you can achieve may be unrealistic. So be very careful in diagnosing what the problem is now. A lot of previous treatment, residual subluxation dysplasia, and a long leg. Can you solve it? And please remember that teenage years and indeed teenage hips are full of angst, and now may not be quite the right time to be doing anything too much. Now, what about stable dysplasia? We recognize this concept in the infant, but what about in the child? This young lady of 14 is entirely asymptomatic. I cannot persuade her to have a symptom. She's a cross-country champion, and the MRI shows a congruent hip with no labral tear. Shenton's line is beautiful, and that acetabular index has not changed since aged 5. I know I should do something, but am I aiming for excellence, or is perfectly okay perfectly okay? Should we treat the hip before it fails, but how hard do I push this particular family to work out what the problem is? So when do I pull the trigger? When I'm concerned clinically and when I'm concerned radiographically. Thank you very much.
Beautifully illustrated as always, Debbie. Thanks so much for that. So it was interesting, as we were doing the polling, I informally polled the faculty to see what their perspectives were, and I think it was a little bit different than the audience. Amongst the faculty, there was pretty much consensus that everyone would operate on those 12-year-old hips you showed, and I think that most people said, as you did, staged. So there is a slight difference. All right, so once you've decided you are going to do an osteotomy, now you have to choose which is the right osteotomy for each case, because we know that not all hip dysplasia is created equally. So we're going to hear from Salil again in San Diego, who's done some outstanding work on analyzing the different types of osteotomies, and he's going to tell us how to choose the right one to do.
All right, great. Thank you. Thank you, Pablo. So again, disclosures, but nothing relevant to this talk. We've spent a little bit of time talking about the hip joint developing as one intact onlog with a cleft that forms and then fully developed by 11 weeks of gestation. We also heard that the majority of the shape is determined by 8 years of age, but it's important to remember those secondary ossification centers that come from the triradiate cartilage, as well as each of those individual bones of the pubis, ilium, and ischium, and when they appear and when they close. So I think some of these hips that you see at 9, 10 years of age that you're worried about maybe being retroverted or decreased anterior coverage, some of that coverage shows up in the mid-teens. And then we've also talked about these two different types of dislocated hips. So something that's referred to as a jump dislocation or infantile hip dislocation, where the acetabulum is smaller in size and the femoral head tends to be larger, versus the childhood dislocations, which may be considered as a slide. So they tend to have a larger acetabular volume. So basically, when you're approaching a child and trying to decide whether or not a pelvic osteotomy is required, you need to figure out exactly the type of dysplasia they have and how your intervention can affect that pelvis. So there's several different osteotomies that are commonly used. We touched on the Pemberton, the Salter, the Dega. I would just add the San Diego to the mix with all of these people who have contributed to our understanding of the acetabulum and different ways to change it. I would just touch base on clarifying the differences between the Dega and the San Diego. I spent some time with Professor Chubak to understand the details of how the Dega procedure are performed in Poland, and to see how the medial cortex is left intact with the Dega, as well as the 1 centimeter of bone near the sciatic notch, versus the San Diego procedure described by Dr. Mubarak and Dr. Wenger, where the medial cortex is cut in the front and back of the acetabulum. So this talk is really to look at whether or not there's actual differences between these types of osteotomies that are performed. And the best way that we thought to analyze this was to use 3D printed models. So we used 3D printed models with dual materials, basically a more flexible material that could be used for the triradiate cartilage and pubic symphysis, and then a more rigid material called ABS that's used for bone. And we had 14 patients with acetabular dysplasia that were evaluated with a preoperative CT scan. We printed models of all of these patients and performed mock surgeries on the 3D prints and analyzed them with this 3D technique to quantify the coverage of the femoral head in a 360 degrees around the acetabulum and see how these different procedures affect the different coverage as well as the volume of the acetabulum. So just to touch base a little bit on this 3D analysis technique, this is what a typical acetabulum should look like, with the most amount of coverage directly superior or lateral with a coverage angle of 120, which corresponds to a lateral center edge angle of 30 degrees, and then more open in the front with less coverage versus more coverage in the back with a typical anteverted acetabulum. And then when we're assessing these patients in clinic and determining, where they're deficient and where our surgical procedure should intervene, we compare them to a cohort of age and sex matched normal patients to really define exactly what we're trying to accomplish with our surgery. So in this 3D printed model study, we looked at pre and post-operative changes after that mock surgery and did some statistics to compare those differences between osteotomies with a significance set at p less than 0.05. So our main findings was that the acetabular volume did change for all 4 of these osteotomies, but that the Salter osteotomy had a significantly less decrease in the volume at 6% compared to about 15 to 20% for the others. And you can see that Salter was significantly different than the other 3. And then in terms of where the coverage changes are happening, so this is a busy slide, but if we look at the 5 clinically significant regions of the pelvis, starting directly superior, working your way anterior as well as posterior, you can see that the different osteotomies had different regions that had significant changes in the coverage. So to kind of boil that down, with the Salter osteotomy, we found that we got the most coverage directly superior. With the Pemberton osteotomy and the Degas, we got the most amount of coverage superior, superior, anterior, and anterior. And with the San Diego osteotomy, again, performed in like the traditional published version, we got the most coverage directly superior as well as in the posterior segments. So again, when you're looking at your patients with DDH, this is just another study where we looked at the regions of acetabular deficiency in 74 hips that were treated in our institution, again, compared to 244 control hips for their age and sex matched controls. We found that there was a pretty broad variation in terms of the acetabular dysplasia. So 44% had global dysplasia, 30% had primarily anterior dysplasia, and then the remainder shown there. So once you understand where the deficiency is and you understand where the coverage from the different procedures can be obtained, you can really specify the procedure that's done for each individual patient. So some of the take-home points, this was the first study to define the significant differences in acetabular volume and coverage changes between the 4 commonly used pediatric pelvic osteotomies. It's important to understand patient-specific acetabular deficiency and utilizing the appropriate osteotomy for that patient. So in our hands, Salter osteotomy is ideally suited for redirection of an infantile acetabulum that tends to be smaller in volume. And then there are modifications of the Degas and the San Diego that can be used to give more anterior or posterior coverage depending on what's needed. Thank you.
Thanks, Salil. Outstanding work you're doing, and we have a lot to learn from you. So you touched on a few of these different osteotomies and how they've been developed. And we're now going to hear from my good friend Xuemin Liu from Beijing, telling us a little bit about how they have developed a minimally invasive approach to performing a triple pelvic osteotomy. Xuemin, it's great to see you.
Hi, Pablo. Thank you. Thank you. And this is to various modified pelvic triple osteotomy procedures available, however, minimally invasive approach needs to be developed in future. This study is to introduce a novel minimally invasive surgical approach that minimizes the times of intraoperative fluoroscopies and size of the surgical incision, as well as its review of results. Ischial osteotomy, we call it one finger technique after identifying the interval between the adductor brevis and pectineus. In the index finger is inserted through the interval between the adductor brevis and pectineus. The fingertip is directed towards the acetabular and the obturator externus muscles. As the finger pushes obturator externus, the ischial ramus can be perceived beneath the muscles that covers the surface of the ischial ramus. After reaching surface of the ischial ramus, the obturator externus muscles and the obturator membrane are bluntly separated from ischial ramus using Kelly forceps, and through this window we can cut the ischial ramus. Pubic osteotomy could be finished in the same approach. Iliac osteotomy by windows and gluteus attachment intact technique. Incise the external oblique muscles at the external oblique muscles insertion to expose the insertion of iliac muscles. Use periosteotomy, periosteum elevator to push the periosteum of the iliac away, and at the same time push the external oblique and the iliac source to the inside of pelvic, exposing the inner plate of the iliac. This will be the inner side of the iliac bone osteotomy windows. Detach the origin of the tensor fascial that are about 1.5 centimeter proximally, while retaining the origin of gluteus medius and minimus. Expose lateral aspect of iliac by elevating the periosteotomy and extension of the joint capsule. The iliac vein epiphysis bearing technique, when the osteotomy passes the anterior edge of the acetabular joint capsule, change direction of the osteotomy to a more distal direction and cut the iliac bone in an L shape through the anterior inferior iliac spine. Acetabular repositioning. Following completion of the osteotomies, chain screw is inserted into control positioning of the acetabular. Use the T-handle to clamp the osteotomy fragment and then turn it into anteversion and valgus and internal rotation. Post-operative management and evaluation. Hip joint abduction brace is used for 3 weeks post-operatively to maintain the hip joint extension and abduction at 30 degrees. After removing the brace, joint range of motion exercise and abductor strengthening exercises are encouraged. 6 weeks post-operative, partially weight bearing is allowed, and after 12 weeks, full weight bearing. Radiological evaluation are performed, reviewing acetabular index, CE, and MP by using AP review of the pelvis. We find acetabular index and CE angle improved very well. Also, migration percent improved, very good. This is some cases. We performed this 7 years boy with LCPD on right side. we use minimal invasive triple osteotomy or the acetabular side, and Stauberg 3 score achieved during 23 months follow-up. 8 years ago with bilateral DDH, she has been reduction and osteotomy history before she came to my hospital. So we use minimal invasive triple osteotomy, bilateral, and the deformity of proximal femur were corrected concomitantly. Serine type 2 was achieved on both sides during 25 months follow-up. So we can get conclusion based on our findings. G3 time minimally invasive TPO could achieve favorable results for hip dysplasia with open choroidal cartilage complex and in LCPD patients who require surgical improvement of the femoral head coverage. This technique could make pelvic triple osteotomy procedure simpler, safer, and more effective. Thank you.
Great talk, Shuimin, and you've been instrumental in developing this in China, and I think it's people like you who will continue to ask these questions and find ways to improve. We were due to have a Q&A, but again, we're a little bit behind, so I'm just going to move into the next block. And at the end of these talks, then we will have some time for some questions. There is one question about improving the reliability of positioning of these osteotomies and how version can be affected in this. But in order to get onto this, what I'd like to do is bring up Ernie Sink, who is just stepped out of the operating room and is going to join us now and tell us about the current state of the periacetabular osteotomy and the development of it. Ernie, thanks for joining us. I know you had a busy morning.
Oh, it's a blast. It's great to be here. I think I just pressed the forward, right? I didn't have the training. So I'm so glad. I actually had the second case cancel because of a little cough, and it was like the best thing. So I can be part of this live. It's great to see everybody, at least virtually. So I'm going to talk about a little bit about the current state of periacetabular osteotomy. It was developed in the 80s, 35 years ago, by Professor Gons and colleagues. And surprisingly, the techniques of the bony cuts has remained very similar over that period of time. But there's been a lot of approach modifications that different people have to limit soft tissue damage and scar and to improve postoperative rehabilitation. It should be thought of as a balancing of the maloriented horseshoe-shaped acetabular cartilage over the femoral head, which leads to an optimal use of a limited area of hyaline cartilage for weight bearing. We don't increase the weight hyaline cartilage, but we make it more efficient. Let's go back one. I view it as a continuum of osteotomies in pediatric orthopedics. When I started, it was you had to do something by age 5, as there was an obscure surgery that was only done in a few places in skeletal maturity. But now I think it's a continuum from Salter, Pemberton, Triple, and PAO, depending on the level of maturity. The benefit is fragment mobility. You leave the posterior column intact. You can correct acetabular version and subtle abnormalities. It remains extra-articular, and it maintains the abductors. Currently, we're doing smaller incisions. We do rectus-sparing approaches. We use transischemic acid and cell saver to decrease blood loss. We can do it with hip arthroscopy at the same time. The correction can be more personalized depending on the type of deformity that they have. The complications for a big surgery like this are relatively minimal, and there's reliable outcomes with a lower vision rate. And over the years, as we learn more about the hip, the indications have expanded. They are symptomatic patients in most cases, where imaging, including oftentimes CT, MRI, and X-ray and exam, has some deficiency, anterior, posterior, lateral, global, or iatrogenic. And we look a lot more than just the lateral CE angles. In 2003, in this paper, Gons mentioned that the coverage may be deficient in more regions than the classic anterior lateral. And this was highlighted in a recent paper by Jeff Wilkin and Paul Boulay out of Ottawa. And they have a classification of symptomatic acetabular dysplasia that discusses the different sorts of dysplasia. The classic dysplasia anterior lateral is shown here with a break in Shenton's line, scale immature patient, good cartilage, upturned sourceal, and tonus angle. And this obviously is a good example of the classic indication for a periacetabular osteotomy. But now we're seeing things three-dimensionally with patients coming in with hip pain and deformity, and this is under coverage anteriorly. The anterior aspect of the acetabulum just never fully developed, leading to anterior overload. You can have the same posterior laterally, where you have acetabular retroversion or posterior undercoverage. This can even have impingement in the front if they're overcovered in the front. Or you can have combined version abnormalities where both the femur and the acetabulum are deficient, for example, anteriorly, and you need to address both sides of the joint. And more we're seeing cases of iatrogenic deficiency after hip arthroscopy, where there's been alterations to the acetabular rim as well as the labrum, and the capsule is never fully healed, leading to symptomatic dysplasia. Mild dysplasia is more recognized over time as we're seeing patients, increased amount of patients with hip pain. Instability is the pathomechanics. There's no subluxation in this group. The lateral center edge angle is 18 to 25, and can be version abnormalities. If we look at the natural history studies that have been recently done, helping us guide in numbers, what is normal on an AP pelvis and what can lead to arthrosis, a lateral center edge angle of less than 25, a tonus angle of greater than 8, less than 80% femoral head coverage, or shallow acetabular depth has been risk factors for progression of arthritis on observational studies. Currently, the incisions we make are smaller, more of a transverse incision that's better cosmetically appealing. And then you can also see you can do arthroscopy distally. Everybody does the PAO with a little different flair depending on their experience and their training. But in the end, we have to assess correction. Depending on the surgeon, some people will use an AP pelvis. Sometimes you use just fluoroscopy. We use fluoroscopy, but now we've added imaging at the end where we use this Radling software that can interoperatively show our pelvic tilt, so it mimics the standing AP X-ray, and that really helps us to make sure we're correcting it in a functional position so our acetabular walls are well balanced, and then we can basically dial in the lateral CE angle we want. The outcomes, and Professor Mills is on this, he's got one of the longest term papers in North America, but on that paper, 75% maintain their hips at a mean of 18 years. The Burns series, that's a few years old now, so 30% survival at 30 years in the initial series. And a recent paper by Wiles out of the group at Mayo showed that the PAO does affect the natural history of hip dysplasia. For example, if a patient has a PAO and is tonus 1 at the time of surgery, the mean time they stay in tonus 1 till they go to tonus 2 is 18 years. And that was better than their natural history. Outcome variables, things that are important. There's many papers with different things, including age, sex, etc. But if there's minimal arthrosis, tonus is 0 to 1. In some tonus 2 patients, you may do it if they're younger and they have good motion. They have to have good joint congruity, impingement-free motion after surgery, and appropriate acetabular correction, including version. When we looked at our outcomes, just how often this surgery is now used for hip pain as well as deformity, are we improving patients' symptoms using PROMs? We found 85% of cases at greater than 2 years felt better with the MCID, reaching MCID with a modified Harris hip score, and PASS was met 67% of the time. We wanted to look at variables in patients that don't feel better, hoping that we could perhaps learn from them or maybe not do the surgery on them. But what we found is there wasn't any specific one variable that stood out. This was greater than 2 years, and there was no variable that differentiated those that had a substantial clinical benefit from a minimal clinical benefit. And this included when we compared scope PAO versus PAO, age, previous surgery, femoral version, and alpha angle. As far as complications, what we worry about is femoral and sciatic nerve palsies, which have decreased over the years. Implant-related issues such that require removal or exchanges are now what we're seeing sometimes is some metal allergies. Delayed unions, posterior column stress fractures can occur, usually observed and improved. Hip flexor tendonitis is not uncommon, especially at the 6 to 12 month period, but the majority of these are treatable. Adjuvant procedures are often discussed with a PAO. You can do an osteochondroplasty, hip arthroscopy, proximal femoral osteotomy, and surgical hip dislocation. Arthrotomy is used to evaluate for iatrogenic impingement, as we do know that if you have residual impingement after a PAO, it can actually lead to worse outcomes. So there may be improved outcomes with hip arthroscopy. And this is an example. When we use it, we do 3D CT studies, and if we have a significant CAM lesion, especially limited range of motion, we'll open the joint and do an osteochondroplasty at the time of a PAO. There are still some uncertainties that we're trying to understand, such as what is the role of hip arthroscopy and labral repair at the time of PAO versus PAO only. There's now a prospective randomized control study in the anchor group that's trying to answer that. When do we need to address femoral version with a PAO? What about ischiofemoral impingement? And again, there's always a debate on the mild or borderline cases. When we looked at the mild dysplasia in adolescents, we found these are usually young people with congruent hips. They did very well after PAO, although they have a significant preoperative non-operative treatment, which is preferred. Labral tears are very common in intraarticular pathology with hip dysplasia. We wanted to compare the groups that had a hip arthroscopy and labral repair versus just a PAO only. And in 2016, we published this paper, and it showed not much difference between the two groups. We repeated this just recently by our fellow last year, and just are finishing writing it up. But what we found is that true groups are not statistically significantly different from each other, which means either we're picking the right ones to do the scope PAO, or it doesn't matter in most patients. There is 2% of the patients in the non-scope PAO group, just the PAO only, that went back for hip arthroscopy. Proximal femoral osteotomy is used to improve congruity. If there's significant torsional malalignment, like patients that really can't compensate for this, Perthes or proximal or pediatric femoral head deformity. And here's an example of a patient who has both acetabular and femoral anteversion, and she walks with a significantly internally rotated gait, so we address it on both sides of the joint. We have not found that femoral version really impacts outcomes on PAO surgery, but about 5% of the time with significant anteversion, we've had to go back and do a femoral derotation osteotomy, but the majority of times, if they're compensated, we don't have to do anything to the femur. We now do surgical hip dislocation in PAOs with Perthes or pediatric type deformities, or if there's an osteochondritis dissecans or OCD in this patient, we're able to use an allograft, fresh frozen allograft, and do the PAO. Ischiofemoral impingement is more and more recognized, but it's where the lesser trochanter impinges on the ischium. We've found that it's in about 18% of patients on MRI preoperatively with PAO, and it actually increases postoperatively, but in very few patients as it creates symptoms. So in general, I think the PAO is a great surgery to improve symptoms in the vast majority of patients. There's not necessarily a consistent variable for failure to meet MCID, indicating the importance of picking the right patients, as well as making sure expectations are discussed with patients preoperatively. And we're doing more work to assess the role of arthroscopy, osteochondroplasty, femoral osteotomy, and acetabular correction. Thank you.
Thanks, Ernie. That was great, as always. So to conclude this block, basically, and I'll end it afterwards talking a little bit about something you touched on, the best practice for labral tears. But before we get to that, it's great to talk about these procedures, and we can discuss a little bit about the best positioning and how you assess version specifically. I think this is one of the issues which we should discuss, but it's not always easy to learn how to do these procedures. And I think that's one of the things that is often left out of all of these studies. It's not the same to have a PAO done by Teddy Slongo or Ernie Sink as it would be someone who is doing their first PAO. So someone who is an expert in this and has been doing them for quite a while with very good results is going to tell us her experience in how to learn to treat hip dysplasia in adolescents and young adults. And it's my absolute pleasure to introduce Stephanie Poon from Stanford.
Thank you, Pablo, and thank you for inviting me to participate in this really great event. And you gave me a really awesome topic. Some people spend a year learning how to treat hip dysplasia in young adults and adolescents like myself, and I'm still learning. So I'll try to condense all of the most salient points into about 7 minutes. So hip dysplasia exists as a spectrum, and the more severe hip dysplasia, such as a developmental dislocation, usually presents and is evident pretty early in life. But the more milder types of dysplasia usually take many more years to become symptomatic and may not present until early adolescence or young adulthood. As we talked about earlier, today, the acetabulum grows from 3 separate growth centers, with the acetabular analog early in life, followed by the triradiate cartilage being active to expand the width of the acetabulum until later on in childhood. And then finally, the acetabular epiphyseal growth centers are active in deepening the acetabulum and establishing acetabular version into mid-adolescence. So growth disturbance at any point of any of these growth centers up until early adolescence can result in acetabular dysplasia evident at skeletal maturity. Growth of the proximal femur is also mostly due to the proximal femoral physis, which is also active until early adolescence. And so disturbance of the proximal femoral physis can also lead to proximal femoral dysplasia, including coxa magna, coxa valga, coxa breva, and the high-riding greater trochanter. Clinically, when you evaluate adolescents and young adults with hip dysplasia, they usually are female. They may be very flexible, and they usually have a family history of some type of hip disease. They may or may not have had childhood DDH. Their symptoms are usually insidious in onset, activity-related, and the symptoms are usually present in the anterior hip or groin, sometimes in the lateral hip. On physical exam, usually they're very flexible. There's pain with hip range of motion, particularly in hip flexion and with the anterior impingement test, as well as the anterior apprehension test. They oftentimes have a limp as well. For imaging, we usually get a standing AP pelvis and measure the lateral center edge angle and the tonus angle. In dysplasia, the lateral center edge angle, as Ernie has mentioned, is less than 25 degrees. And for the tonus angle, we have usually thought of it as dysplastic if it is elevated over 10 degrees, but more recent studies have suggested maybe a lower cutoff of 8 degrees. We also obtain a false profile view, which is a 65-degree oblique view of the hip. And we can measure the anterior center edge angle. And with dysplasia, that is usually less than 25 degrees. So the treatment for acetabular dysplasia in the skeletally mature is a periacetabular osteotomy, which Ernie has shared many great examples of the PAO, and it's a very powerful surgery to correct acetabular dysplasia. For proximal femoral dysplasia, a proximal femoral osteotomy is sometimes needed either to correct varus or valgus deformity and rotational deformities. Relative femoral neck lengthening can also correct a high riding greater trochanter and any impingement that could be secondary to that high riding greater trochanter. Some special considerations in this population, I think, include 4 different things. The first is whether or not the patient has residual dysplasia from childhood DDH, or if they have newly diagnosed dysplasia as a young adult. In adolescence, I think sometimes it's a little tricky to decide when to intervene, if they have symptoms or if they have asymptomatic dysplasia, and also how skeletally mature the adolescent is that may influence the type of osteotomy that you choose to perform. In adults, we consider their age and the health of the joint and also cartilage quality. So when we talk about hip dysplasia in adolescents and young adults, with residual hip dysplasia, these are usually patients who had an earlier diagnosis of DDH, and they may have residual acetabular dysplasia or femoral deformity, and they may have had prior treatment or prior surgeries. So usually the patient and the family are aware of their prior hip issue or diagnosis, and you can sort of jump into more of a discussion of treatment options and how this happened with a better understanding already existing with the patient and family. Whereas the patient who is newly diagnosed as an adolescent or adult, sometimes the dysplasia may be less severe, so they've had no symptoms for decades, and they are very surprised that they have this developmental deformity that has been going on since childhood. And they may have had misdiagnoses or prior surgeries before coming to you. So these patients oftentimes need a little more counseling with education about what hip dysplasia is before jumping into treatment options. With adolescents, the symptomatic adolescents with hip dysplasia, clearly treatment at this time is usually considered. But with the asymptomatic adolescents, so this is maybe someone who had childhood DDH that you've been monitoring, and radiographically they have residual dysplasia, but they don't have any symptoms, or it's dysplasia that was just caught on another X-ray for some other reason. And for these patients, I think it can be a little bit tricky to counsel them as well. We know that both the severity of dysplasia and activity level influence the age of a patient presenting for treatment for a PAO. And so, I think counseling these patients about activity modification is important if they're asymptomatic and they prefer to watch and wait. But there may be a role for intervening in an asymptomatic patient if there's very severe dysplasia with subluxation. Another thing to look out for is for in adolescents whether they are skeletally mature, if the triradiate is still open or not. And your options are typically either a triple osteotomy or a PAO in this gray zone of the early adolescence. And we don't really know the answer, which is better at this time, but Dr. Millis and I looked at our patients, and between the two of us, we found 13 patients with an average age of 11 years with an average 4-year follow-up. And we found in our patients, we had no intra-articular fractures or non-unions, but we did see 5 premature triradiate closures in the operative hip. Despite that, all patients had significant improvements in their lateral and anterior center edge angles and their acetabular index and extrusion indices. And this correction was persistent through to skeletal maturity. So it can be safely done in the PAO with an open triradiate cartilage, but probably in surgeons' hands who have quite a bit of experience doing PAOs in the skeletally mature already. In adults, Ernie touched on this too, you consider their age, the health of the hip joint, the amount of intra-articular damage, and you also have to discuss with them quite in detail their individual goals. So if you have a 35-year-old or a 40-year-old with desires to keep up with her young children, desires to be very active, and you discuss their function, pain, and quality of life goals, what their short-term goals are, and also what their long-term goals are. Some people prefer to just wait and have a hip replacement at some point. So it's an individualized approach to counseling these patients. We know that the 30-year outcomes from burn showed a 30% survival rate overall for their early cohort of PAOs. But when you look at this cohort broken up, stratified by age and also amount of osteoarthritis, the tonus grade, really you can see that the age of the patient and the amount of osteoarthritis are really two strong predictors for survival rates. So it's really important to counsel patients about that. In general, the younger the patient, the higher likelihood of a healthier hip joint with less intra-articular damage, and potentially they might have a more significant benefit to delaying arthroplasty, especially those patients who are still skeletally immature. For older patients, likely there's more intra-articular damage inside the hip, and there's a higher risk of failure of hip preservation surgery. So potentially there may be a less benefit to delaying arthroplasty if they're already in their 40s, for example. So we tend to be a little bit more aggressive in saving the hip when the patient is younger and there's less arthritis, and a little less aggressive with saving the hip when the patient is older and there is more arthritis. So in summary, for the adolescent hip with dysplasia, there's a difference between counseling patients and families when there's residual versus newly diagnosed dysplasia. Treatment of asymptomatic dysplasia depends on the severity of the dysplasia and the patient and family's expectations. And the choice of redirecting pelvic osteotomy in the skeletally immature or nearly skeletally mature, sort of in the 8 to 12 years old range, is perhaps a surgeon's choice. So if you're like Dr. Liu, who has a lot of experience with a triple osteotomy, then that might be his choice of surgery, whereas for someone like myself, I'm much more familiar with a PAO. That may be my surgery of choice. And for adult hip dysplasia, I think a PAO can work very well if the tonus grade is 0 or 1, if there is preserved joint congruency on functional views of the hip on X-ray, and after thorough discussion of the risks and benefits, if our expectations match between the patient and surgeon. And total hip arthroplasty is probably better if there's tonus grade 2 or higher osteoarthritis, and if there's incongruity of the joint on X-rays. Thank you very much.
Thank you, Stephanie. That was outstanding as always. So we do have a couple of questions which have been coming in, mostly being congratulations to all of our presenters for some outstanding presentations. Most of the questions seem to be related to, again, the accuracy of the positioning after doing any of these osteotomies, and if there is any use. I'll ask you, Stephanie, because you just spoke. Do you think there's any role for navigation when doing a PAO to more accurately position the fragment?
Yeah, I think that is great technology, and definitely there is a role for that. It's probably more useful for maybe the low volume PAO surgeon to help to figure out exactly where to put the acetabulum. For Dr. Millis, it probably doesn't matter so much. He probably knows exactly where to put it without navigation. But I think certain situations, such as the skeletally immature or nearly skeletally immature, where the posterior wall isn't fully ossified yet, I think that may also be a good role for navigation.
Yes, excellent. Thanks. I think it's technology we don't quite know how to use yet. So I'm going to close out this block before we get to some pearls of wisdom from both Teddy Slongo and Mike Millis. And my only disclosure for this last talk is that I'm a poor replacement for Ira Zoltz, who was the original speaker, but unfortunately had to decline at the last moment because of some family commitments. And I'm going to talk a little bit about best practice for labral tears, but it's going to be a slightly philosophic talk on the labrum. And I think the amount of attention that this small structure surrounding the acetabular rim has received in recent years, it really is quite remarkable. Perhaps MRI has only increased our awareness. These are two side-by-side images of hips with the corresponding MRI, which were read by our radiologists as discrete labral tears. Both of these had been treated for developmental dislocations, the one on the left with a Pavlik harness and the one on the right with an open reduction. But I wouldn't really consider these to be labral tears, yet they were read as such, and the family was very concerned because they're much more aware of this now. This dislocated hip came back with a report from radiology that said there was a complete absence of the labrum. And after we did a closed reduction, they read this as labral hypertrophy and a discrete labral tear in the same patient. They first said there was no labrum, then they said it was hypertrophied and had a discrete tear. So I'm sure you're all aware that the scientific output about the labrum has increased exponentially in recent years. And it's always interesting to go back, and you can find one of the first mentions of the labrum in 1933. However, that paper actually refers to Drosophila melanogaster, the common fruit fly, whose genetic sequence makes it ideal for research. And the mouth organ of this ghastly looking creature has a semicircular structure, which is actually called the labrum. And although it has nothing to do with the labrum we're discussing today, I'd like you to keep in mind this paper from 1933. References to the acetabular labrum have also grown exponentially, although they're not quite as extensive as the ones looking at the fruit fly. The first one I can find was by a Scottish gentleman by the name of Ian Patterson, who in 1957 mentioned treating a torn acetabular labrum by open operation and resection. And a couple of years later, Thomas Dameron in North Carolina reported this paper in the JBJS, where he said it seemed to serve a useful purpose. And he felt that this strong structure had an important function and should be replaced if possible. Perhaps this is the genesis of the repair versus resect debate. But the problem is, I don't think we're necessarily comparing apples to oranges, and I don't think all labral tears can be considered the same, especially in the setting of such a broad spectrum of pathology as we see in hip dysplasia. Perhaps we need a more dynamic approach. I have been recently incorporating ultrasound into my evaluation with a gamut of findings, which honestly, I don't quite know what they will mean. On the left, you see what I think is a normal labrum, which is homogeneous. Then as you move towards the images on the right, you see the femoral head below, and that structure just above it is the labrum. And the images on the right appear to be cystic changes and degenerative changes, which can be evaluated with real-time ultrasound, especially with reproduction of the patient's symptoms. Now, ultimately, looking inside the joint is the best way to define labral pathology. And the anchor group were crucial in showing us this with an arthroscopic classification of labral pathology. And you could make the argument that doing an isolated arthroscopic repair doesn't compromise outcomes, but that's probably not true. This paper from Boston evaluated patients who underwent a PAO after failed arthroscopy and showed that results were not as good when patients had a previous arthroscopy. So there might be something more to this. It isn't only the labrum. There are other intra-articular findings which are not uncommon. Ben Dome showed us this one with hypertrophy and fraying of the ligamentum teres, which some believe is a sign of microinstability. And in general, they have considered hypertrophy of the labrum to be consistently present in patients with dysplasia. But again, the anchor group led by Woody Sankar in this case showed us that in fact, the labrum can have a standard size. The devil here is in the details. Unfortunately, I don't think our imaging is of high enough fidelity and reliability to know that we're truly consistently talking about the same thing in these patients. So what to do in the setting of dysplasia and a labral tear? As Ernie mentioned, the group at HSS published this and found comparable results in patients undergoing periacetabular osteotomy with and without an arthroscopic labral repair. So this isn't without logistical issues. It increases the operating time, and in most instances, it requires two surgeons, one to perform the arthroscopic part and one to perform the osteotomy. So it's not that easy to do. And in fact, most studies evaluating the impact of arthroscopic labral repair, including this paper from Japan, show that patients do not have a worse outcome without labral repair after performing a periacetabular osteotomy in the setting of dysplasia. If the bony deformity is corrected to a more normal anatomy, the results have been consistently good with this redirectional osteotomy. So, of course, the gold standard for most studies in medicine is a randomized controlled trial. And I give full credit to the study which Ernie also mentioned that Paul Bewley is leading from the Anchor Group for undertaking an attempt at a randomized controlled trial. However, I have to say that I think the hypothesis is prematurely biased, stating that concomitant hip arthroscopy at the time of PAO will result in a clinically important improvement without any significant increase in cost is inherently flawed, especially given the colossal variability amongst surgeons, technique, pathology, and as has been brought up multiple times, expectations. I think it's very unlikely that even amongst a group like this, we would reach a consensus for what should be done for this hip with relatively mild dysplasia and a small but discrete labral tear. And even if we did achieve that consensus, the outcome would be highly variable given the almost artisanal nature of this kind of surgery. So to go back to our friend Drosophila, research by so-called Drosophilids has actually yielded no less than 6 Nobel Prizes in medicine since 1933 when that first paper was published. I think it's highly unlikely that with our primitive orthopedic definitions and interventions that we'll come anywhere close to this. And in closing, I think the evidence to date just is not strong enough to recommend routine repair of a labral tear in the setting of acetabular dysplasia. But I'd be interested to hear what others on this panel feel about this, as I do have a bias since I do not perform arthroscopy. And I see Ernie raising his hand. So Ernie, what's your thoughts on this?
Well, part of it is, part of the issue is the concept of a labral tear. I probably spend the first 10 minutes on every new consult trying to explain that it is not a tear per se. It's either detached or it's irritated. Because a lot of people feel if they've been told something is torn, that of course it needs to be repaired. And so the terminology is one of the issues. And then they often will come from sports medicine surgeons that say you need your labrum repaired. And so when they come to you, they're told they have a labral tear, but this thing called dysplasia. And so you're going to repair the dysplasia, but what about the tear? And so one of the things I've had hard times getting into the study is the expectations, because if they still have some residual pain, it's very common, what about the labrum? And wasn't it torn? So I do think there's an issue. I don't think on our studies that it makes a significant difference whether you do a labral reattachment or not in the majority of patients. There's a few patients, though, where you go into the joint and the labrum is like a bucket handle or a very hypertrophic, irritated, unstable labrum. And certainly you feel like that soft tissue, because the nerve endings are there for a lot of the anterior hip, and maybe stabilizing that will help the PAO in a certain group of patients. But I agree with you. I think it'll be a long time till we have the answer. And what I tell patients most of the time, I don't think it matters. The only thing is they come in with a predetermined feeling that they have to have a torn thing repaired. And that really makes it challenging.
Yeah, I think, again, that's crucial, because I think when we see patients and the radiology report says this, then it almost forces you into a different decision. But I think it's in the way it's being read. I would ask either of the Simons who are still connected if they've ever seen a labral tear in infantile hip dysplasia. Perhaps Simon Thomas, I see you're still there.
Yeah, I'm just trying to unmute. Not knowingly, no. I'd say I hasn't been there.
Simon Thomas, are you still around?
Yes, can you not hear me?
Yeah.
Yes, I did just answer.
Oh, sorry, yes, I did hear you. Simon Kelly, are you there?
Yeah, just here, just a little bit backlit. Sorry about that. No, I don't recall seeing any labral tears in the setting that you have mentioned specifically.
Because so to Ernie's point, I think this is important. I recently had a patient come in who was 7 years old, and the report from radiology was that, and the family was much more worried about the report of the labral tear, perhaps because of the amount of attention it's received, than the dysplasia, which was clearly more of the issue. And I think Ernie is right. If you correct the dysplasia and don't do anything about what's been reported as a tear, then the family's expectations may be unrealistic. So I'm not sure we necessarily know what we need to define. Again, I think that this term of labral tear, which is very frequent, at least in our radiology reports, has to be refined.
Don't you think, Pablo, it's a little bit like meniscal tears? So if you show a bunch of adult radiologists pediatric knees, they'll call a lot of tears that aren't there. It's a difference in vascularity, and it's probably the same issue here, isn't it? I'd be surprised if we were missing lots of infantile DDH labral tears.
Yes, I would agree with that. And again, I think that's why I just don't think we are good enough at reading our MRIs to truly characterize this and know that we're really talking about the same condition. Okay, well, we're back on time, and I apologize. We haven't had as much time for questions and answers as I would have liked, but I would like to round this out because we've got two fantastic talks coming up. First of all, we're going to hear from Teddy Slongo from Bern, although he's currently in Germany, who's going to talk to us a little bit about the Swiss experience, the evolution and the power of the Bernese triple osteotomy. And then after him, we'll hear from Mike Millis, who is up in Boston and again is one of the most experienced surgeons in the world and can tell us a little bit more about why becoming a hipologist is important. So first of all, we're going to have Teddy Slongo, if we could pull up his slides and go straight into those.
Dear colleagues, it's a pleasure for me to give this talk about the evolution power of the Bernese triple osteotomy. Thank you for the invitation to be a part of this very nice event. So what means power? When you have a look at this X-ray, how we can solve this problem, and you see the result, and the Salter osteotomy was performed, and we have to ask, was the Salter osteotomy adequate method for this problem here, as we have seen? You agree? No, this was not the correct method. Very popular around the world are the intratumoral osteotomies, and very often people are trying to solve this problem of the acetabular problem by intratumoral osteotomy. But as you see, you create a deformity of the proximal femur, but you do not solve the problem. We have still this plastic hip, as you can see here. So then you can think about the combination with the intratumoral osteotomy and the Salter, as you can see here. But you see here in the arthrogram, we have still not the optimal situation. The femoral head is not well covered. So how we can solve this problem? As with the Bernese triple or in a triple osteotomy. You see here a very crazy case with a high neglect dislocation of the hip, and we performed the open reduction by a modified Smith-Wesson approach, and in addition the triple osteotomy. And please recognize no surgery at the proximal femur. This is never necessary in such a procedure. And I hope you agree with me. It's a quite good result of this tricky hip here. Okay, why we have changed? What is the problem in Salter osteotomy? And you see the drawing on the left, you see the problems here very well. So the correction often is insufficient, as we have seen before. But the correction is often insufficient because of the wrong indication. The hip dislocation is not an indication for Salter when you read the publication. And what we can see very clearly on the drawing creates a retroversion, but nobody is aware of this. But this is true. We create the retroversion and later on a pincer impingement. Creates pressure on the femoral head, by lateralization and distalization. And very often it's a surgical or a surgeon problem. The basic concept for the children distal osteotomy is our Bernese PIO, also called Ganz osteotomy, the periacetabular osteotomy. We know, in the meantime, we have many different pelvic osteotomies are historically available. Most are only mono or two-planar, like Salter, Pemberton, or Dega, or these augmentation osteotomies like Mizuno or Chiari. But is this the solution? No. Only PIO and triple are three-dimensional osteotomies. This allows a real reorientation of the mal-aligned acetabulum. What are the considerations for the PIO and the triple? First of all, the most important are the common rotation center. Acetabulum and femur had the corresponding rotation center. This is important. We never create lateralization. In contrast, we can perform medialization. Sometimes this is important and we have to do this. And we never create pressure on the femoral head. This avoids Avian. And this gives an absolute free mobility on the acetabulum fragment. So here I can show you very nice the reorientation of acetabulum, and the reorientation has replaced any augmentation. This is a farm of the Swiss Alps you see with the pipe. And what happens when you make Salter or Dega or Pemberton osteotomy? You rotate a part of the pelvis, and then you see the front of the head is still not covered. So I see this a hanging head. Of course, here you see what happens with the reorientation. The man remains in the same position, but his head is well covered. And this is the effect of the reorientation. We know we have joint preserving osteotomies. Again, the augmentation, but this is the reduction of the joint loading, and we end up in fibrous cartilage, what is not in the long term a good situation. But the reorientation procedure is a changing the orientation of that article surface, and we have always high limb cartilage. We have to think about what is the result of high shear forces, especially if we have not the optimal correction of the acetabulum orientation. This is the damage of the labrum, as we know in the meantime. This 20 years ago, we were not aware of this and all the problems in this hip, as we know. And the question is, can really this operation solve the problem or prevent shear forces? We say no. So what other options would be available? What are the problems? Joint replacement in very severe cases you can always think about, but practically only good function in elderly patients, but for young population it's not to recommend because of the different revision you have to do. Arthrodesis, you have to think about arthrodesis in very crazy cases. Sometimes you have to do this, and in our house it's quite a common operation. We have a lot of patients from Africa, from outside, and they go back in this region, and this is the best situation. No pain, and a young patient can live very well with arthrodesis. And then we suggest with 30, 35, depending on the problem, to go for a total hip. But the best way, if the acetabulum has cartilage, but we need cartilage, is joint preserving osteotomy. When are the indications for joint preserving surgery independent of the age of the patient? When we have symptomatic deformities, when surgery can correct the deformity and eliminate improved symptoms. Deformity which in all probability will lead to early joint destruction. Best time for joint preserving surgery is always before irreparable damages, but sometimes we are waiting too long. And young age, osteoarthritis maximum degree 2, not more, because if you have grade 3 or 4, the cartilage is gone. So even then, reorientation does not help. So in children with a residual CDH or DDH, or neglect hip dislocations. We know not only the Burnett triple osteotomies are known around the world, there are different types. First of all, the Sutherland, but the Sutherland has a very osteotomy close to the symphysis. In principle, is a double, not triple osteotomy. Then we have Löcker, as you see here. Then we have the Steele. Then Tönnies was the first. He made really a triple osteotomy in this way and very close to the joint. But the problem was that he did it in a supine position, and then he stretched the leg up, and the damage of the sciatic nerve was possible, and so on. And then you see our Burnett triple osteotomy goes in this way. But for all this osteotomy, we have to be careful of the sciatic nerve, of course. So Burnett triple and PIO are similar, but I will show the advantage of our triple osteotomy and the difference between PIO and triple. Again, what is common? Rotation center like in PIO, even in triple. Short lever arms, and this is important. Steele, Löcker, they have long lever arms. You will see that all the muscles, the hamstrings are attached to the muscles, to the bone, and this eliminates or hinders the free mobility of the fragment. And we have only the sacrospinal ligament attached, but we can cut it as well, and then we have a free dimensional mobility of that fragment. And we have always good bone contact. Here you see these are the cut for our triple osteotomy in this view, and this in blue you see is the PIO. What is the difference in the PIO? The posterior column remains intact, and we have to respect the growth plate, the trilateral cartilage, so therefore the cut goes out and not behind the acetabulum. In this view, you see again very close, and the PIO as well in this way. So very similar, but the fragment is completely free and the posterior column is not intact. What kind of indication we see for triple osteotomy? Residual hip dysplasia after pretreatment, hip subluxation and hip dislocation in case of neuromuscular disease is very powerful. Perthes disease, untreated or neglected hip dislocation or subluxation, or early impingement syndrome, so-called then reverse triple or reversed PIO. As I mentioned before, we go then to medialization. What is the goal of the triple and the PIO? That means the optimal force distribution in the socket joint, optimal containment, and the containment is the key. Avoiding early hip arthrosis, avoiding pain for the patient, normal function and normal growing during childhood. Therefore, we go out with our cut. So this is not a child, but I will show with this example from Professor Ganz the power of the separate reorientation osteotomies. You agree with me? Normally you will say, you cannot solve this problem. This is old. You will go for a total hip. But this patient is not so old, as you can see. And here Professor Ganz performed a PIO here in this way, of course with a valgization and distalization of the trochanter. And you agree, this hip looks quite good and can survive for the next 10, 15, 20 years, and then perhaps you have to go for a total hip. But here you see a situation in the child, and I guess you see a lot of such a situation after Perthes or other disease in this situation. And the most of you will prefer perhaps a Salter or something like a valgization or something, a distalization of the trochanter. But here you see what we did. We made a triple osteotomy, and we made the so-called relative lengthening of the femoral neck. And look, the hip now has a normal neck shaft angle without valgization, and I guess the hip looks quite narrow. So what are the prerequisites for the optimal result? We need adequate equipment. I see this around the world. I visit a lot of clinics, and they ask me to make a triple osteotomy. And sometimes I cannot do this, even I have really good experience. But if you have not at least some good instruments, it's very difficult. And I guess this is also one of the reasons when you will fail with your triple osteotomy. So we need a good smooth Hohmann retractor reversed and the normal. What we need is long chisels, very sharp chisel, and a laminar spreader. And for fixation, we are using only in kids 3.5, 3 or 2.5 full threaded Kirchner wires. The surgical step in a short patient positioning is important. So by position, radiolucent table, C-arm position in this way, of course. Then you see our approach. Here you see on the left side, this is the iliac spine, then the modified Smith-Peterson approach, and for the ischium osteotomy, it's a Ludlow skin incision, but then a little bit different. And here in the bone model, you see where the cuts are in corresponding to the pelvis. So here, we start with the partial Ludlow approach. We open then you see the abductor magnus and the gracilis. We go between in a blunt dissection. Abductor brevis muscle with the branches of the abdominal artery we can see here, and this is very easy preparation to go down to the ischium. So here you see then the ischial bone with open periosteum, and we see how wide it is. We are direct here. This hook is direct under the teardrop. We need good smooth hooks. Here in the drawing, you see the position, and here in the bone model. And you see in our situation with these smooth, round Hohmann hooks, we can protect the sciatic nerve. So in our experience over 30 years in kids, we never had a sciatic nerve damage. Then you see here we check the level of the Hohmann hooks under the C-arm, and you see we are directly under the teardrop, and this is really like in a PIO, the same entry point of the ischium like in a PIO. Then with the chisel, we start to make the cut, as you see here, and in this drawing you see we are again like in the PIO, proximal to all the muscles. So all the muscles are not attached at the accessory fragments, and this is important. And then, as you can see, we can visualize the osteotomy, open, controlled osteotomy. And what is important here, and you see this is the most frequent failure here, we have a very strong muscle on the lateral side where the hamstrings are attached, and we have to cut it with the chisel, with the scissor, and otherwise you cannot dislocate the fragment. Now, once this osteotomy is done, we start with this modified Smith-Peterson approach. Here for your orientation, anterior iliac spine, iliac crest is here. This is the tensor fascia lata muscle, and what means modified Smith-Peterson approach. The most of you will go between the psoas, the tensor fascia lata muscle, and the sartorius and the psoas muscle. But then you have the branches of the nerve, and this you always damage the nerve. And here we go in the fascia of the tensor. As you can see here, we open it, and then we are inside of the fascia, and we come down to the rectus femoris. As you can see here, this is a blunt section. The tensor fascia lata muscle is here. All the nerves coming around here, and then we have a good visualization of all our structures. Here then, in the next step, once we have prepared this, we go for the osteotomy of the pubis. We do it from the same cut as you see in this drawing. We pull the skin a little bit to medial, and here this is the psoas muscle. Inside of the psoas muscle is the femoral nerve, and on the medial side with the hook we pull away the vessels, and then we have a free visualization of the pubis. And here again with the smooth Hohmann retractors we go around the pubis very close to the acetabulum, and also here we check it under intensifier, and as you can see here, this is always visual control. Nothing happens in the dark or uncontrolled. Every step is under visual control. Then what is important to know, the periosteum is very thick in this region. We make this cross-section, and then we dissect the periosteum, as you can see on the right side here, very nice, and then the smooth Hohmann retractor goes intraperiosteal to prevent or to protect the obturative artery. And you see here also from the form, we are very close to the acetabulum. What is important here, that we cut away a small wedge for a better dislocation or displacement of the fragment. You can do this with a sharp saw or with a chisel, as you can see here. And here again in the model, you see the protection of the soft tissue as well of the obturative artery and the nerves. Once we did this and completed, then we start to disattach the muscle from the iliac crest, as you can see, and to prepare the iliac wing. And then what is new according the PIO, we start from the iliac crest. Here you see, or the spine, the cut downwards up to this corner and then oblique, as you can see here in the bone model. So this is the incision of the periosteum for the new cut like in a PIO. Then the first cut we do by saw up to this point of here. And sorry, the picture is not very sharp. And you see always our reversed Hohmann retractors protect the soft tissue. Once we reach this point here, the next part, this osteotomy, is performed by the sharp chisel. You cannot do this by a saw, and then this is with a sharp chisel, as you can see here very nicely. Then you bring in this another chisel, and then you break out your fragment. You remember the other two osteotomies are already performed. And then it's important to insert a Steinmann pin in the inferior iliac spine here for better handling of the fragment, as you can see here. With a laminar spreader, we dislocate the fragment. You check that all the periosteal attachments are cutted. It's important, and you see how free the fragment is. In case you need a big or a huge correction, then you can prepare a little bit here deeper. Then you will see the ligament, and you can cut the ligament as well, and then the fragment is completely free. Here you see how we do handle this situation, and we can correct the situation. So here now, it's one of the most important picture and steps. You see very often you pull on the fragment in this way, as you see here. And then the fragment goes outside, and this creates retroversion. And this is what we do in Salter. You know, in Salter you have to do always, because the rotation center is the pubis and is the symphysis. And then you create a retroversion. This happens in 100%, believe me. Okay? Only with the new cut you can prevent this a little bit. Here you see the neutral decision where we are starting. Or you go inside, as you can see, and this creates antiversion. A lot of people are not aware of this, that what means a retroversion, antiversion. And I have seen that people doing such a surgery without any intensifier or X-ray control. You have to control this. So here in the model, I will show you a little bit the effect. You see this is a bone model with a high dysplastic hip, and this is a correction. A lot of you will say it's not bad, but it's too less lateral correction. You see the corner here is not. So here we have too much posterior wall. The fragment is rotated. Here we have too much anterior wall. This is Salter, exactly, the retroversion. And here now, this is a correction, as you see in the line of the situation. What is important through the operation, again, I mentioned this before, that we are able to make X-ray control. Here I will show what this means. This is a preoperative X-ray of this plastic hip. Here, the first correction. I remember we had guest doctors in the OR, in the theater, and everybody said, oh, it's fantastic correction by Professor Ganz and I. We said, terrible correction. This is not correct. Look at this. This is an overcorrection, and this is a retroversion. So you see too much anterior wall. You have to recognize this. Then we made the correction, a new X-ray. It looks better, but we are still not happy. Still too much coverage here. Then you see we made it again, And when you compare now, this looks much better. You see, now we have anterior, posterior wall in a correct way, and you see postoperative X-ray looks perfect. So we must be critical and we must be able to correct this. In younger patients, we do this by arthrogram, or I will show you later how we do this. So here you see exactly how we make the dislocation. We rotate the fragment in the line of the spine. The technical fixation is also important. We fix it like a supracondylar fracture with 3 Kishore wires in this way. This gives a very, very high stability, so we never need a hip spica. So what we should avoid to fix this is the fragment in this way. The fragment in this way is never well fixed because this fragment can rotate, so we should not do this, or of course we should not do this because 2 Kishore wires in the same way are not better than 1 or 3. So please do not do this. So examples. Here again, this case before, we do always an abduction view. We see no reduction is possible, so we had to go for an open procedure. And here you see the steps again. The contour of the ischium level for ischium osteotomy, then the pubis control, and here the intraoperative control here. The needle here indicates where we have the labrum, the cartilage of the acetabulum, and as you see here, it looks quite good, and the long term is okay. So again, no femoral surgery, femoral shortening, and you agree with me, the femur now looks normal. We remove normal in kids the Kishore wires from the iliac crest, but this Kishore wire remains in place because it's too much operation. No formal shattering is required. Exception is the CP patient, cerebral patient palsy. I show you here the example. Of course, how you can solve this problem here. Again, you see here the steps, open reduction. Here we combine with shortening and intradocumental osteotomy and the triple osteotomy, and you agree for a CP patient looks quite well, and see here the healing and the situation. Other example, you see always the same step like in a cookbook. Visualization under a C-arm, a bilateral dysplastic hip. First on this side, I criticize myself a little bit. This is too much correction. We have realized this too late, and but it looks not bad. But for me, it's a little bit too much. Here on the other side, we did the same operation, but here now I show you the trick. We open the capsule. We bring in a bended Kishore wire to visualize the anterior border. So now you see the difference. Left looks better than the right side. Okay, this is correct. The right is a little bit overcorrect. Other example, a Pertus, 10-year-old boy. You see here, very good. And again, always the same control, the same steps. And here again, you see the Kishore wire to indicate the anterior border. And now here you see the evolution, and you agree with me, this looks quite good. And again, you see no surgery on the proximal femur. Another case, 8-year-old boy, Pertus, left with subluxation, but no hinging. This is important. There is no hinging. So again, we perform always an arthrogram to see what happens, where is the head, and then the 3 steps, good correction, you see powerful. But here we created a little bit of retroversion because we needed this, because the acetabulum was very dysplastic, but you have to recognize what means retroversion, that we see the iliac spine here and that you see the foramen obturatorius is not symmetric to the other side. In a normal situation, it's always the same, but the result is good here, as you see, but still you see that this is a little bit of retroversion. So what kind of problems or complications we can see? I will say 3 types. You can make technical failures, surgical failures. You can have general complications as nerve lesions, sciatic nerve, but you should avoid this. And one of the biggest problems is the wrong indication. And what are the results of these complications? Again, 3. No reduction or no containment, remaining dysplastic hip or redislocation, or you create an Avian of the femoral head, or as I have seen of the acetabulum as well. But all this you can prevent, because the problem is usually not the method, it is the surgeon's lack of skills in this surgery. Again, you have seen this picture before, what kind of problems, complication. The Salter was not a good indication, and the fixation was not good. Look here, shortening of the femur, and a kind of a pemberton osteotomy with partial necrosis of the acetabulum. So we should not do this. And you have seen, and this was my first case, this problem we can address and solve with a good triple and good open reduction in an absolute perfect way. But when we started, we made also some failures. You know, you look this 32 years ago, we performed really an overcorrection. Here you see very well. So the trerial cartilage came to the loading zone. This was the situation before, you see, then the correction. And this is the problem. This was over coverage. What we have learned, we made no many such cases, but we were aware of this. And the other problem you see here, the non-union of the ischium. We can solve this problem in the meantime. Why this happens in very young patients? You know, the synchondrosis here is not solid, and the hamstrings are on this fragment and pull the ischium downwards, and then the quadratus femoris muscle goes between here, and then, as you can see here, and this hinders the osteotomy to heal. But this is not a big problem. The patient has normally no problem with this. Nowadays, when we have to do a big displacement, we bring a piece of bone inside. Otherwise, we never use bone graft. The other problem is exactly what means the negative Salter effect. As you see in this bone model, here is we have the sacral like a ligament, and this is behind the rotation center. And when we pull only on the fragment, then the sacrospinal ligament rotates the fragment, and this creates always the retroversion, because this is a so strong ligament. With a triple, you can cut it as well. But again, as I mentioned before, with the new cut, we can preserve this. Other technical failures, fixation. Look at this. I guess these are not adequate fixations, no, not good results. So here, the best technique is, as I mentioned, in this way, and in this way. And here you see this was a steel osteotomy with the long lever arm, so all the muscles are attached here. This is the problem, and this is the correct fixation. But you can create other problems. You see, look, where is this Kishore wire? On the model, I have visualized this. Goes inside here and can damage the sciatic nerve. I have seen this in cases. Or what you see here, you can perforate in the joint. I cannot understand how we can do this, and you can document this. Okay, so I come to a short summary. What is the more adequate situation? You see here a bilateral dysplastic hip, and on the right side now, today with animation, we can do this intratracheal osteotomy. What happens? It remains comes to a shortening and still dysplastic hip. And here I simulate a triple osteotomy, and you see in the triple osteotomy we have a good coverage, adequate length, no malunion of the proximal femur. So this is the secret and the power. So thank you for your
I think, again, seeing these procedures in the hands of the people who have really been developing them is a unique experience for everyone. And your experience and wisdom in this have been truly incredible. So in the time we have remaining, I'm very excited to conclude this symposium with a talk, which again is going to lean on more of a philosophical tone. And after that, we will have some time remaining for some question and answers with the faculty, if everyone's willing to remain on. But I couldn't think of a better way to finish this symposium than listening to a good friend of mine, Mike Millis, who is one of the most thoughtful people I know, who is going to talk to us about becoming a hipologist. And to have the chance to spend a Friday afternoon listening to Teddy Slongo and Mike Millis, for me, is the equivalent of playing under the lights at Arthur Ashe Stadium at the US Open. So I'm very grateful to everyone for joining, and especially to Mike for giving us this talk on why it's important to become a hipologist. Mike, thanks so much. And I believe Dr. Millis is still on mute.
Am I unmuted now, Pablo? Can you hear me?
You are, yes.
Oh,
great to hear
fabulous.
you.
Great. It's good to be heard. So this is indeed an honor and a responsibility. Being a closer is a special role. Everybody has listened a lot. I've been fascinated and have learned a lot today. Your symposium, Pablo, on experience, judgment, and wisdom it's a terrific concept, and it's really been terrific, and it's reality here. So going forward, this is my experience now being a student in a new way, looking reflectively at this whole field. So I'm a fervent hipologist. This is a disclosure, definition to come. And I do have a confluence of interest with everybody in this symposium. I believe strongly in the role of mechanics in hip dysfunction, but I'm increasingly aware of the impact of factors beyond the mechanics that impact our outcomes and our delivery of care. And so that's the background in which I present my experience. We all have lots of people to acknowledge, and there's not time to acknowledge all the people who have helped me learn what I've learned. But I'll start by presenting this slide. Dietrich Tonis, Heinz Wagner, John Hall, a personal mentor of mine, and all the rest of these people, including Chad Price and Kishore. And Pablo, you, I acknowledge, in pulling this kind of an effort together. This is really terrific. What do we desire as hip surgeons? Well, again, these are my biases. These are my thoughts. Well, we all like to undertake challenging work in which we're successful. And we've heard the presentations today of very successful, very thoughtful surgeons. We want to feel good. We want others to feel good. We love acclaim, self-satisfaction, and gratefully admiring patients and colleagues. Clinical technical excellence, we got to have that. You know, we'd like to feel we're among the best, and we'd like to feel that we're getting better all the time. What is wisdom in the non-technical aspects of the profession? That will be my focus. We've heard a lot about the technical aspects. Those are really important. Well, how do you get to be regarded like an Indian tracker or Yoda or maybe a hip whisperer? Well, what does this mean in 2021 terms? To me, this means experience and excellence in gathering information. It means identifying the problems that you're being asked to solve. It means skill in analyzing data, which in turn can create the information. And then, of course, you have to execute. You have to have the technical skill. It's necessary, but not sufficient for optimal outcomes. And feedback and response as part of a learning system. And what I call connection. You know, this is a lot that wisdom is. So this is the big picture, maybe. You know, you got a shallow hip socket, you want to get it better covered. Or you got one that's too deep, you want to uncover it a little bit. In the end, you want to achieve balance. You want to achieve balance. You want to get homeostasis again. You want to restore the organism to normal. Well, what's hipology anyway, this made-up term of mine? It's a science. Indeed, it's a study of the hip. It's a study, though, also of the patient affected by hip-related disorders. It's a recognition of the complex systems within which the hip works. It's a philosophy. And the hipologist, to me, has a respect for preservation of the native hip. He or she has a respect for function, a broad biopsychosocial perspective extending beyond the hip. Because mechanical function is very important, but it's not the only concern. Well, we're here today because we're all artisans. We're craftspeople too. And hip surgery is a powerful tool with risks and benefits. It's got biological aspects and technical or mechanical aspects, unquestionably. So what are key questions about hipology? This is one of my favorite paintings at the Boston Museum of Fine Art. And Paul Gauguin asked, where do we come from? What are we? Where are we going? And you can modify this to think of ourselves as hip surgeons and hipologists. At the AOS, often there is a flash 5 presentation in various areas. So these are my flash 5s. Number 1, hipology involves much more than hip surgery. It concerns all that goes into optimizing care for these patients. It's a philosophy, it's a scientific discipline, and it's a craft. So that's point number 1. Point number 2 is that there are discussion framers as we look at hipology broadly. There are people, there are connections among these people, and there are ideas or philosophies. Well, some of my most important people have been these. These are historical figures, they're great figures. Unfortunately, a number of them are gone. And it's one of my privileges to reintroduce some of these people to you if you don't know them already. You know, Maurice Mueller, for example, who was Professor Ganz's mentor, Sugioka, Tonis, Salter, Professor Ganz, of course, and Jeff Mast. These are some of the greats, and you should go back and read some of their original work. For me, this was my immersion course in hip surgery with Professor Ganz, Professor Wagner, where I was privileged to go first in 1979 and a number of times later to Germany, in southern Germany, where I had an AO fellowship. And this was just pivotal in my understanding, not just about the hip, but about the patient and about function. There were some great Heinz Wagner quotes. The average surgeon is an average surgeon. Not every problem has a solution. Sophisticated operations are for sophisticated patients. But he believed that sophistication can often be taught. A failure to plan is a plan to fail. And restore function and bone structure will care for itself. Hipology connections for me must include the anchor group, which has done critical prospective studies, protocols, and assessment tools. Powerful network, a wonderful group of people from whom I continue to learn on a daily basis. But this has been for adolescent and adult hip surgeons with their focus in those areas, although pediatric orthopedists have been a large part of that group. Then there's IHDI. Again, powerful worldwide networking and collaborations. And Chad and Kishore and Woody, crucial in that group. Again, connections, people, and I think that connections and collaborations are a large part of what makes hipology what it is. What have I learned in 40 years of clinical hipology? Well, I've learned that we're not usually dealing with patients who are totally well. Usually they're mechanically unwell in some way that is compromising the way their hip works. So we're trying to figure out where these unhappy hips and unhappy patients are on a spectrum in the mechanical universe, although you can view this slide of red-green zones as much more than a mechanical diagram. At any rate, we have to figure out where the people are, where we want them to go, and how to get them there. And so our interventions can be viewed as vectors, but you have to have a clear sense of what you're trying to achieve and what the problems are if you're going to have any chance at success. Indeed, this is the implication of this is that, of course, the symptoms aren't always directly correlated with mechanics. There are other important factors in our outcomes, This is a picture of Anne Mannion, who's done a lot of great work with the Bern Group and in Zurich at the Schultes Clinic in dealing with expectations and how that affects outcomes. This comes quickly to asking ourselves about the role of teams and multiple perspectives. An expert team is better than a team of experts, and any hipologist is a member of a team. This is a semi-enlightened view here. Our closely knit hip team in Boston, which includes attendings, fellows, research coordinators. But if we fast forward to our present thoughts, a la 2021, care teams are patient-centered. That's best. There are many diverse contributors to the best outcomes. But here's the most important person, the patient in the middle. And a lot of other people contribute to the best outcomes, way beyond just getting the acetabular fragment in the right place. Not that that's unimportant. A lot of what I've learned is indeed that I'm still learning and trying to improve. And this relates to my getting data, good data, converting it to information, getting good feedback, and modifying my behavior. I've learned a lot from reading. I've learned a lot from my patients. In terms of reading, Atul Gawande is a great place to go. He's written a terrific book called Better, in which he asks these questions of you, makes these suggestions to you in becoming a positive deviant, how to be better. Ask unscripted questions of your patients. Don't complain. Count things. This means analyze what you've done. Write things down and change. So how does the hipology virus strike? What happened to me? How did it happen to me? How does it happen to others? Well, there's an appeal of renowned hip surgeons like these. There's an attraction of hip science, if you will. The hip is a fascinating organ system. I clearly was attracted by cool hip surgery, and hip preservation surgery is awesome. It's usually a combination of the above things. Well, how do you become great at this? I think you have to be a true believer and an advocate for the native hip and for the patient with a hip problem. I think you should commit yourself to never-ending learning. You must collaborate. You must believe in mentorship. So have mentors no matter what your age, and be a mentor if you can. How do we advance our field? Well, I think we must all learn individually. This includes collaborating, but not just with orthopedists. Collaborate with others who are not orthopedists. Narrative. What about hearing the patient's story and connecting? I learned a lot at a terrific course I took from Rita Charon, who teaches a great course at Columbia and heads a great department at Columbia. This is a great text, Principles and Practice of Narrative Medicine. It's enlightened me about listening, hearing, acknowledging, which is essential for connecting. Connecting encourages communication. Communication leads to better information transfer in every direction, and this has got to lead to better decisions and better outcomes. The biopsychosocial model was first talked about in the 70s by a psychiatrist who understood well that there was a lot more than just what people viewed as biology. There was also the social and psychological side of things. This may be a little bit boring and scary to an orthopedist, but this is the new reality. David Ring wrote a great editorial just a few weeks ago in the Journal of Bone and Joint Surgery. Mental and social health are inseparable from physical health. This is absolutely impossible to ignore. So my education in hipology, hapology, if you will, is that there's a value of multiple perspectives. The patient's perspective that we don't always appreciate is most important. The patient's expectations are usually not the same as the surgeon's, no matter how well we think we explain things. Major surgery, no matter what the age of the patient, no matter how well done, is a major trauma, not just physically. And most important perhaps, patients are great educators for other patients, for orthopedic surgeons too, especially over years of follow-up. Yoichi Tsujigaoka taught us that hip preservation is regenerative medicine. This is a short but brilliant article that everybody should read. And his point is that radiographic bone healing and post-op recovery of muscle strength are not the only important factors in healing. The patient has to recover in all kinds of ways, but restore function and the bone structure indeed will take care of itself. So in closing as a closer, I'm going to bring up these points. Sources of wisdom are far beyond physics and surgical orthopedics. Einstein said it very well. Information is not knowledge. The only source of knowledge is experience, and you need experience to gain wisdom. Well, for me, my experience has been really helped by listening to my patients. My patients have been incomparable teachers for me, for their peers, and to ignore their experience is unwise. So this says, don't judge my path if you haven't walked my journey. So Megan Lance is one of my most insightful patients, and she's my own PAO patient mentor. And she has said, connect, make eye contact, sit, listen, have humility. If you don't know, say so. This will gain you respect and trust. And she suggests we remember Napoleon's words, be realistic, but give hope. Dr. Hall, a brilliant, wonderful man whom I miss daily. These are his words, and this is what the nurses wrote about him in the plaque in his old OR at Children's Hospital. The room is dedicated to compassion, respect, and excellence. Good words to live by. So I'm thanking my fellows and my colleagues for all they've taught me, as well as, of course, my patients, who are perhaps my most important collaborators. So thank you, Pablo, for the opportunity to present this work, my thoughts, my perspectives. There are a lot of references for people to read at their leisure that have also taught me almost as much as my patients themselves. Thanks again for this opportunity.
Well, thanks to you, Mike. They say wisdom is a gift, and I think that I have been given one of the greatest gifts of all time in having all of you join and have all of this wisdom gathered at this meeting. We do have some minutes left, and there are few questions remaining from the audience. Many are related to the learning curves with doing these procedures and how safely you can begin to perform this, and how do you evaluate someone's technical proficiency in doing this? Maybe one of you, Teddy or Mike, could answer that. How do you assess someone as being able to do these procedures adequately?
Well, that's a great question, and there's no perfect answer to that. I think it's mentoring, it's insight. There are some interesting papers on this. Don Howie is an orthopedic surgeon in Adelaide, the professor there, and he made a great effort to learn PAO at a great distance. First, he visited Professor Gons. He had Martin Beck come and spend a year with him. And then afterwards, he was also remotely mentored. And his article is a good one about how you sort of jump the learning curve. I mean, I think ideally, you look over someone's shoulder for a while, you read, you do cadavers, you are supervised in gaining gradual competence. But there's no perfect way to know. And it's a little scary for everybody as more and more responsibility is assumed. But I think that there are no super shortcuts. You have to be honest with yourself and your mentor, I guess. That's my best guideline I can give.
I completely agree, Michael. Absolutely. This is the way how to learn this. And of course, you know, when Professor Gans or myself, we started together, of course, we had the ability to go to the cadaver lab, and we performed many of operation on the cadaver to study this. But the big advantage of today is actually not in the last 1.5 years, but not allowed to travel, but is to visit one of a very experienced surgeon, as you did it in Bern. I remember when you was in Bern with Professor Gans, and of course, this is the best way. The big dangers I see around the world that a young colleague learns such an operation not in second hand, third hand, or fourth hand. That means he learns from a surgeon who learns also second hand or third hand, and then more and more failure happens. You know, the best way is still to see really the master himself, and to stay with him only for 3-4 operations. Then he can show you the main steps, and normally every of us is a good surgeon, but he has to know what are the difficult steps, what are the important steps. On the other side, you said mentoring, it's important. Yes, and nowadays mentoring, you can do this worldwide. I have a lot of connection by email to colleagues from China, Russia, up to South America. And if you have a good relationship, you can teach them today really step by step, by good drawings, by good pictures, and then he send you back the first case, and then he must be open for criticism, and then you show him how to do it a better way. So mentoring is the way.
Yeah, I couldn't agree more. I think that's a great point in mentoring, and you have to be willing to learn this. I still struggle a bit, though, because although it's obviously ideal to visit and travel to these places, it's not always possible. And you know, countries who are in underdeveloped regions don't always have the ability to do this. Not everyone can pick up and get on a plane and go to Bern and spend the time there, or go and spend time with Mike Millis. So I think it's also something which we would do well to develop pathways that can be taken into different locations. And I think that that's something we should be leading on. Do either of you have any thoughts on that?
I have a lot of thoughts in that. I don't know whether Kishore is still on the call, but we did a mini expedition to, Ira and I and Paul made a mini expedition to Kishore. Not that this is an underserved area, but sort of to try out how we would, package PAO and try to teach it at a remote site. And that's just one example of our trying. Kishore can comment on how that worked. That was just sort of a short couple of days. But I think to some degree, we who can mentor should, once the pandemic gets controlled, try to go other places and help. I mean, I think, again, it's not Mike Millis going to India to do 25 PAOs in Vellore. The whole idea is go to Vellore, do a couple of cases with Vrisha Maduri, and then Vrisha over time learns. And, you teach people to fish, you don't fish for them. So I think that's ideal.
And we should also profit now a little bit from the Corona time, because during this time we have increased all the online education. And actually, I will do this now for Africa and also for China. We have very good equipment that we can do or demonstrate operation online in a good way, and good connections. And of course, it's not so easy to teach in an online version by a video. But today, this is very simple. And I guess with this technology, even in low-income countries, we can bring we can learn these people to do this in a correct way. We should profit from all these new technologies much more.
Thanks. Yes, I think if we could bring all of the speakers into the presentation room, because we do still have all of our speakers on, and I'd still have a few minutes, which I think we can discuss some more issues. One of the things I have found is I think we need some more disruptors in this. And I remember reading, I think it was Mark Twain, who said that if you find yourself on the side of the majority, it's time to reform. So although I think it's fantastic that we can all agree on this, clearly something is still missing in this. And I think Kishore, who unfortunately did have to leave, is on the right track with building up this hip health network around the world. I find that we need to do something to disrupt the status quo. The fact that we continue to discuss these issues at this level slightly disturbs me, because I don't think we have done as good a job as perhaps we would like to think we have. Is it time for someone to disrupt the status quo as far as teaching, maybe even from a more basic level? Should we be the ones who are truly reaching out to our pediatric colleagues, to our primary care colleagues, to our family medicine colleagues? It's great to do PAOs. We're surgeons, we like doing that. But even the most prolific surgeon can only do so many. Should we be finding better pathways, things that could be implemented by the many and not the few?
Well, I think you're absolutely right, Pablo. I mean, I think that every PAO we do, to some degree, is a failure of screening. And I don't think you can pick them all up as babies. I think there are some adolescent dysplasias that are always going to occur. But, you know, I toy with the idea of screening all the adolescents too, because everybody who's got hip dysplasia that's symptomatic at age 35 had it at age 15. And it would have been better to correct it at age 15. You know, there are all kinds of issues here, but certainly there are a lot of failures of screening and early diagnosis that are embarrassing. And I mean, this is, I think, a large way to go, rather than trying to make even better our PAO techniques.
I agree.
So what would your ideal strategy for screening for adolescent onset dysplasia be? I'm not sure we have one, and I hate to put you on the spot with that, but what would you say it is?
Well, let's just say, first of all, you know, this is like going through all the stages of grief. First of all, you can't deny there's a problem. And I think, Pablo, you're right. Let's disrupt here. Let's agree there's a problem. I don't have a great solution to the problem yet, because you can't get a standing AP hip X-ray on every patient. You know, another thing is slip epiphysis. My God, I mean, let's just focus on the ball here with DDH, but slip is another horrible failure of screening to a large degree. But let's just say we need to screen better. I mean, I think we need to screen better somehow. I think this is a condition that in a lot of ways is just begging for better screening. Now, you know, there are cost issues, there are accessibility issues, there are all kinds of issues. But I think we should all agree that earlier diagnosis is a key to better outcomes. So I don't have it all worked out yet, but I'm gonna pound my fist on the table. I'm a disruptor right here. I'm a disruptor. We got a problem, and I'm not gonna shut up.
Well, thanks for that. Yes, and in the words of Heinz Wagner, not every problem has a solution, but we should be identifying the fact and trying to find these solutions.
Absolutely.
Does anyone on the faculty have any questions for us? Because that's it. We've run out of questions from the audience. Does anyone have anything else they'd like to add? If not, if I could get everyone to turn on the cameras for a moment, we can take a group photo, and I'll give everyone back 15 minutes of their lives today, which we're able to make up by keeping on time. So I very much appreciate everyone's effort in doing this. Yes, I see everyone's back except Perry Schoenecker, who we see his background, but we don't see his face. All right, well, I'm going to take a photo, and once again, thank everyone for your incredible enthusiasm and effort. And as Mike said, hopefully once COVID is passed, we will be able to do this in person. And the virtues of the virtual world have also helped us. And I think this wouldn't have been possible with it if it wasn't for this technology. So thanks to everyone for an incredible day, and looking forward to seeing everyone in person next year.
Thank you, Pablo. Congratulations on a great meeting.
Thanks, Pablo.
Thanks very
Thank
much.
you.
Marvelous.